Excellent. So thank you so much again. I mean, you know me, most of you. My name is Fakada Selassie Henok Mogas. I'm a physician from Ethiopia, currently practicing in the US. So I'm not going to talk much about myself today because most of you know me one way or another. So this is a continuation of our website presentation, and thank you everyone who is participating to make this event a reality, especially the team of great medical students from all over Ethiopia, taking part in organizing this series of lectures. So I'm going to start with a case presentation. So I will pretend as a patient. So there is a time dedicated to give us your differential diagnosis at the beginning. I think it's about 5 to 10 minutes. So we will limit it to 5 minutes. That means you have to really participate as fast as possible to save time. Okay, please try to engage. So our today's case is this patient presented with weakness of right side of the body and right facial droop, and it was a sudden onset, and the patient is a 65-year-old female patient, and she was brought to St. Paul Millennium Medical College emergency department. Okay, so now I think you can go ahead and give us differential diagnosis, a sudden onset of right-sided body weakness and facial droop. I'll write down your differential diagnosis. Just, start shooting, huh? I cannot see the chat box, so Gamachu Leroy, you can help me with the reading those answers, okay, in
We
the
have
chat.
a stroke. We have one person basically has a stroke.
A stroke, okay,
Maybe thoughts paralysis.
Thoughts paralysis, okay. So whoever is suggesting this differential diagnosis would be given the opportunity to speak up. So you justify why you are considering stroke, thoughts, paralysis, and all that. Okay, go ahead, please.
Resina has said it could be a brain tumor, relapser as well.
Brain tumor.
TIA.
Huh?
TIA, transient ischemic.
TIA. Okay, so TIA and stroke, they should be together. So I will bring it up. TIA, stroke. Okay, what else?
Resina has said an abscess.
A brain abscess. Okay. Brain abscess. You can also speak up, okay? Huh?
We can consider a consequence of meningitis.
Meningitis. Or infections in CNS infections in general.
Spinal cord neoplasms.
Spinal cord tumors. Weakness of the right side of the body, which is sudden onset associated with right-sided facial droop. Okay, that's the presenting complaint. And she was brought after a few minutes after the onset of her symptoms. Okay, 65-year-old female patient.
Yeah, there is tuberculoma in the chat. Tuberculoma.
Tuberculoma. Okay, tuberculoma infections. Okay, tuberculoma.
Conversion disorder.
Conversion disorder.
And there is demyelinating disease in the chat.
Demyelinating. So like I always say, when you are mentioning a differential diagnosis, don't just mention a book title, demyelinating disease is a book title, it's a very broad differential diagnosis. So what kind of demyelinating disease are you considering in this patient? You should be focused, okay? So spinal cord tumors, I can take it benign versus malignant. That is fine. It's also a big chapter, but we can take it as tumor, mass lesion. But a demyelinating lesion, or diseases, if you have a specific differential diagnosis, just mention it, okay? What else? Guys, be mindful of our time limits. You know, we dedicated 5 minutes for differential diagnosis. So anything else?
Satellite, I think epidural hematoma.
Epidural hematoma. So subdural hematoma or extraaxial bleeding. You know, they are extraaxial bleeding. So, okay. What else?
And consider venous thrombosis, maybe.
Dural venous thrombosis. Okay.
Peripheral neuropathy.
Peripheral neuropathy. Secondary to what? So, I mean, you know, some of the differential diagnosis is even based on the chief complaint can be excluded at this point. Who wants to exclude some of the differentials here? But, you know, go ahead and tell me if there is a more differential suggestion, let me know. And then I'll give you a chance to exclude some of these differential diagnoses based on the information we have at this point, okay?
Drop of peripheral neuropathy. Maybe we say bracket myasthenia.
Myasthenia? Huh? Myasthenia?
Lambertitan.
How do you spell it? Lambertitan, I forget it. Lambertitan, I don't know.
Oh.
Is that right? Is that right? Did I spell it right? You will correct it anyway. I don't know. I'm not sure. Lambertitan, I'm not sure. I can Google it right. Any other differential diagnosis? Otherwise, let's exclude some of them just based on the information we have. Is there anything you want to include on this one?
Satellite cerebral vasculitis.
Okay, so excellent. Cerebral vasculitis. Good. Anything else? Uh-huh. Anything else? Oh, I have to make you a host again, Leroy.
Oh.
I'm sorry. I have to give you allow where is you make a host, make a host, make a host. Yes, yes. Do you want to change the host to Leroy? Yes. Oh, oops. And then it took everything away from me. Shit. Oh, my slide. Oh, can we have multiple hosts, guys? Or how do
I think Leroy, I think you can adjust the setting to allow everyone to share their screen.
Yeah, let's do that, please. Because my screen is gone now. I'm sorry.
Okay, doctor. I had made you a host again. Can you make me host?
Can you change? Can you change? Okay, yeah, I can share my slide now. Thank you so much.
I made you the host, sir. Yeah.
Oh, you made me the host. The problem is I cannot admit people. That is the problem. Because I'm not paying attention. So I'll try my best. Okay, I will try to multitask. That's fine. Okay, let's finish up this part, guys. Do you want to add any other differential diagnosis? 65-year-old female patient who came with sudden onset right-sided body weakness associated with right-sided facial droop. Sudden onset. So 65 female. You have listed these differentials. Do you want to add more, or shall we exclude at least some of them based on the information we have so far? Is there anything more, Leroy?
No, no one is texting.
No one is texting. So very good. So what kind of stroke are you thinking? Do you want to be specific? When you say stroke, it's broad. There are different types. So which one do you want to consider in this patient? Or what are the possibilities of the different types of strokes?
We could further maybe specify if it's an ischemic stroke or a hemorrhagic
Ischemic
stroke.
versus, okay, we'll talk about it further later. Ischemic versus hemorrhagic. Okay, sounds good. So I think we can keep stroke, right? So do you want to keep a stroke? It's right-sided body weakness with facial droop. We can still keep this one based on the information. TIA is the same thing, transient ischemic attack. We can keep it. Torts paralysis. What is torts paralysis? Whoever suggested, whoever has. Uh-huh.
I was the one that suggested torts paralysis. It's
Okay.
a phenomenon that occurs after usually an epileptic seizure,
Uh-huh.
where patients present with facial weakness,
Okay,
sometimes
so
as well as extremity weakness.
okay.
Now, the
So
absence of the patient having a seizure,
Mhm.
I would rule the differential.
Yes, so
Minus.
post-ictal seizure is
Yeah.
less likely because the patient didn't provide an information that she had an abnormal body movement and
Exactly.
she didn't present with abnormal body movement. So torts paralysis was post-ictal state or post-ictal paralysis is less likely. I'm going to kick it out. Okay, so do you guys agree? I think it should be out. So we didn't have that information of seizure, so it's out. What about brain tumor? What about brain tumor? So if we discuss about these differentials right now, so we are just like, setting the background so that it becomes easier for us to discuss them further when we get, adequate information later on. So let's invest some time on this level. This is a very important part of our presentation. So brain tumor, do you want to keep brain tumors?
I would like to put tumor, brain abscess, and tuberculoma all together. Just
First,
call
brain
it
tumor.
brain mass.
Yes, brain tumor. Do you want to keep brain tumor? Let's go one by one. It's a nice idea. I will come to you when we reach there, but like, brain tumor. Do you want to keep brain tumor at this level? And why or why not?
Vista says brain tumor won't be. Says brain tumor won't be sudden onset.
Yes, brain tumor is some sort of a chronic process, a chronic pathology. So even if the patient is presenting to you with weakness, most of the time it's going to be progressive, long term, and it's not going to be a sudden onset. But there is one situation in which, like, brain tumor may present to you with an acute onset, a sudden onset weakness of extremities. What is that? What scenario is that? There is a mass, and the mass was not noticed by the patient or symptoms were not really severe, but like all of a sudden patient may come to you with weakness. What is that possibility?
In the chat, we have people saying if it bleeds, a
Yes,
bleeding tumor.
tumor bleeding, right? So like, if a patient has a tumor and there is, bleeding within the tumor, there will be an associated edema formation and pressure in the surrounding areas will be significantly elevated, and that may present with a sudden onset of weakness. So tumor, brain tumor, but if it was acutely bleeding, okay, within the tumor. Okay, brain abscess. Do you want to keep brain abscess?
No.
It is a good differential diagnosis for right-sided body weakness, but the fact that the patient presented suddenly makes brain abscess less likely because an abscess forms within a couple of weeks, days, even weeks or months. Maybe if it is an acute bacterial infection, it could be in a matter of days. So the presentation wouldn't be a sudden onset. So less likely I kicked it out. Meningitis, CNS infections, what about that?
Highly
So brain,
unlikely to cause
highly
body
unlikely.
weakness.
Yes, thank you so much, Leroy. Very unlikely because, like, a patient with meningitis would have other presenting complaints, right? So, like, headache, neck pain, fever, pills. The patient would be more toxic. The patient was sick at least for a couple of days or a day or two. And the weakness may come if there is, associated, neurologic sequelae related to the bacterial meningitis, viral meningitis, whatsoever. So very less likely because the patient was apparently okay. She just presented to us with a sudden onset right-sided weakness. So that makes meningitis and sinus infections less likely. What about tuberculoma? There are about 18 18 people, so try to participate, you know, and in the future, maybe, who knows, including today, Those people who are actively engaging, participating would get a prize. What is that prize? Nobody knows. So what about tuberculoma? Even if there is no incentive, your incentive is you have an opportunity to discuss this kind of challenging cases with different people. So use the opportunity, guys. Tuberculoma, yes or no?
Chat, anybody?
Huh?
People should at least text in the chat.
Yeah, at least take us in the chat with your reasoning, okay? If you say yes, why? If you say no, why? Okay. Let's not kill our time. Let's be as far as unlikely without pulmonary symptoms. Okay, so Yapsara is suggesting it's unlikely without pulmonary symptoms. It makes sense, but like you may have tuberculoma without having prominent symptoms in the lung, but majority of the time, tuberculoma happens in a setting of pulmonary TB with disseminated tuberculosis and all that. So tuberculoma is a chronic condition. It's not an acute condition. It takes a while for a mass lesion or an abscess related to tuberculosis to form within the brain parenchyma. So it's not an acutely presenting problem. So tuberculoma is less likely. So we'll kick it out. Spinal cord tumors. What's against the spinal cord tumors? The spinal cord tumors could be a possibility. That is right, because they can compress the spinal cord and right-sided body weakness can happen. But the problem is, in this particular patient, there is something else in the presentation, the facial weakness. No, doesn't explain the facial. Yeah. So the facial nerve involvement, Dabiba, thank you so much. Razina, facial droop, one talker. So it's very unlikely or less likely to get facial weakness or facial palsy in a patient with a brain tumor, so that makes it less likely. So spinal cord tumors are less favored in this particular patient. Conversion disorder, yes, it is a possibility. It's a psychiatric issue, psychiatric manifestation of certain stressful situations and all that. Some people may develop weakness of the body and all that, but it's not common as such to have facial droop, right? So that makes it less likely. Number one, and number two, it has to be a diagnosis by exclusion. So you cannot say, oh, this is a conversion disorder, and you can't ignore the patient unless you rule out other important differential diagnosis is. So number one, it shouldn't be sitting high up, so it has to come down. And number two, it has to be a diagnosis by exclusion. If you want to keep it, I can keep it for now. Do you want to keep it?
Oh, yes, that's that.
You want to keep
Yes.
it for some time? Okay. I will keep it for some time, but it's going to be at the bottom. We have to exclude other pathologies. Okay. Epidural hematoma, subdural hematoma, demyelinating diseases, demyelinating conditions. Can you give me examples?
Like multiple sclerosis?
Multiple sclerosis. Yes, multiple sclerosis is one of them. So multiple sclerosis, as you know, can involve the brain parenchyma, the brain. It can also involve the spinal cord. So what is really characteristics of multiple sclerosis?
There would be ocular involvement. One.
Yes, ocular involvement is one of the commonest, right? So, patients may have diplopia, double vision, problem with their vision and all that. And they can also have weakness of extremities if their spinal cord is involved or more part of the brain parenchyma, the brain is involved. But the other thing is multiple sclerosis has a typical characteristic, right? Is it an acute illness, a chronic illness? How is it characteristic? How does it manifest?
As Zabiba
The
says,
weakness.
progressive weakness.
Yeah, the weakness is sometimes it comes sometimes it goes, there are periods of relapse. It could relapse. It could also resolve by itself with treatment or by itself, and it relapses. So it comes and goes. So it's not just a sudden onset weakness of extremities, facial droop. That's not characteristic of multiple sclerosis. Patients may have, ocular manifestations. They may have weakness here and there. And there is also time as well as spatial spatial, I don't know how to pronounce it, spatial distribution, right? So the lesions could be here and there at multiple levels, and at the same time, one lesion comes now, it resolves, and another lesion shows up at some other point. So this patient, she just presented for the first time, sudden onset. So that makes multiple sclerosis less likely. Do you agree, guys?
Yeah.
Do you agree?
I think we agree.
Okay, sounds good. So in that case, I'm going to bring it out. What other demyelinating diseases do you know? Hmm?
Have in the chat GBS.
GBS, yeah, GBS is another differential diagnosis. So if you want, we can say MS, we can say GBS. Okay. So what's against GBS is also, do you think this patient has GBS?
In
Uh,
GBS, the weakness starts in the lower extremities and it
Yes.
goes up.
yes.
Yeah, most of the time, bilateral lower extremity weakness would be the presenting complaint. Plus, it is gradually progressing. It's not going to be sudden acute. Yeah, of course, there will be some weakness at the beginning, but the weakness is going to be progressively increasing. And most of the time involves the lower extremity musculature first, then it can ascend up. Okay, so it's just an ascending paralysis, another terminology. So GBS and multiple sclerosis, they seem to be less really favored in this particular patient. All right. So, and GBS will also have some other, problems prior to the weakness develops, like, GI infections, right? Diarrhea and all that. So respiratory infections could precede the weakness. So that part is missing. This was apparently healthy 65-year-old female patient with sudden onset right-sided body weakness and facial droop. So less likely to be of MS and GBS. So at least we mentioned them. I will remove them. They are less likely. Mind you, so the reason why I'm doing this is because, like, when you are a physician, your friends were asking me, how do you deal with this kind of patients? How do you consider differential diagnosis? This is a step I use. So when somebody tells me, when the emergency physician tells me, oh, I have a 65-year-old female patient, sudden onset right-sided body weakness, facial droop, boom, then I start thinking in terms of differential diagnosis before I even start listening to the detail of the patient's presentation. Okay. So this is a process I use. Is it GBS? I will say, I will tell myself instantaneously, less likely because of this is MS, less likely. Tuberculoma, no, less likely. Could it be brain tumor? It could be, but less likely. I will keep it down. So brain tumor with bleeding, it can happen, but it rarely happens. It's not a common scenario. I will still consider it, but I'll keep it in the bottom. I'll bring it down. This kind of stuff. Okay. So all the differentials you mentioned so far may cross my brain, but that is how I process in the background. And this is what I am trying to show you or teach you as you go along. And with experience and everything, you become more efficient, okay? Because last time people were asking me, how do you approach a patient? Like if it was you, encountering this patient, this is what I use. I start differential diagnosis consideration, starting from the chief complaint. That's why I'm investing longer time here. Peripheral neuropathy, myasthenia, Lambert, and whatever. Do you think these are relevant for this patient?
No.
Very less likely. So, I mean, a peripheral neuropathy, it could be because of diabetes or like, myasthenia, whatever. Whatever the case is, less likely it looks like it's a central lesion because it involves the cranial nerves and it also involves most probably the motor. We don't know whether it involves the sensory function or not. We will see. The cerebral vasculitis?
Unlikely. We would have either relevant history or headache symptoms,
Yeah,
vomiting.
things of that sort. Excellent. So patient will have headache, patient will have another presenting complaints in the background, a patient will have some issues going on for some time. And most of the time, the distribution could be, the involved vessels could be diffuse. And because of that reason, you may not have like, particularly involved focal lesions. Focal lesions can happen, especially if a major vessel is involved, a certain territory is involved. Patients may present with this presentation, but it looks less likely. I'll keep it down. I wouldn't be able to exclude it 100%, we can keep it down. But most of the time, the presentation is not going to be such acute and sudden, okay? So what about yeah, brain tumor? We say that dural venous thrombosis. Oh, we didn't talk about epidural hematoma, subdural hematoma. What do you think about those?
I would like to keep the list maybe further down. Ask
Maybe
further
maybe further
history.
down. Yes, excellent. Because like, you want to know more, right? So was there any history of trauma? We don't know. She may have any history of head injury, whatever. We don't know. So we cannot be 100% sure to exclude that. Probably I'll keep it still there. I mean, I'll keep it still there because, some important data is missing. So we cannot really commit. Dural venous sinuses, sinus thrombosis, dural venous sinus thrombosis.
Similar to the cerebral vasculitis, I want other symptoms. Headache, history of
Yeah.
infection, maybe.
Yes, history of, fascial infection, periorbital infections, symptoms related to vision, headache, and other systemic manifestations might be apparent in a patient with dural venous sinus thrombosis. And headache is also very important. It may be the most prominent finding for this group of patients. Of course, they may present to you with body weakness and all that. So, I mean, the fact that the patient developed sudden onset weakness, no other symptoms reported, facial droop, it seems dural venous sinus thrombosis is less likely. Do you want to add anything? So at least, we started with a long list of differential diagnosis, and now you can see with this simple information, just the chief complaint, how much we could have achieved, So the list is long, but we try to make it shorter just based on this information only, okay? So you should have this confidence, especially as a physician working in a resource limited setup. So this is the type of expertise you want to develop, okay, as a clinician. This is a very important skill. Considering differential and narrowing down differential diagnosis based on clinical information. So I think we can proceed. If you don't want, if you have any question, you can ask questions. If you have any recommendations, you want to add any uh, differential diagnosis or remove one of these differential diagnoses, you are more than welcome. And feel free, and don't be scared of making mistakes. There is no thing called a mistake. It's a thought process. Just forward the thought process. And if it is right, it is right. We'll accept it. If it is not, we'll tell you how we challenge that information or a thought process. Okay? Let me give you a chance to reflect. Do you want to add anything?
I would like to know your thoughts about not about epidural, more about subdural. Even if you don't have history of trauma, this patient is 60 or 62-year-old.
65. She's 65, yeah.
65, so that even makes her at more risk because of the bridging veins. Even without trauma, there is likelihood of the rupture. So without imaging, we might have like straightforward diagnosis of stroke or transient ischemic attack on the top, but how can we exclude without imaging those two special subdural hematoma?
Thank you very much. It's a very beautiful, interesting question you have raised. So subdural hematoma is a possibility. That's why I didn't dare to remove it. Subdural hematoma, as you all know, it's a very common problem in the elderly. He mentioned it, the pathophysiology, most of the time it's because of rupture of bridging veins. And that happens because, old people do have brain atrophy, right? So the brain atrophies, then there will be the space between the calvarium, which is the bone, the skull, and the brain substance would increase. When the space is increased, then these bridging veins will be under a lot of stress. They will be stretched. And even with a very minor trivial trauma, they may tend to bleed. So that's a possibility. And patient, when you ask them about trauma history, they may not remember. Okay, they may not remember. So it's a very important topic. It's still a possibility. That's why we keep it. The only thing is subdural hematoma. Most of the time, it doesn't grow overnight. It's just, the bridging vein. It's a vein. It's a bridging vein, a small vein. And the bleeding is gradual and small at a time. Okay, it's not going to be a major bleeding at the same time or really fast. It's not a fast bleeding. So the symptoms would be gradual. So patients would start noticing weakness, maybe in the hand, and they think they are fine. They think it's because they are numb or anything like that. So the symptom progression is against subdural hematoma because most of the time it's chronic subdural hematoma, which results in gradual onset of weakness of extremities as well as cranial nerve affection in the elderly. Whereas acute subdural hematoma, just like epidural hematoma, is associated with acute trauma, major bleeding, acute bleeding, and the presentation could be sudden or acute. So if you are talking about chronic subdural hematoma, the only thing against it is the progression of the illness. Her presentation is sudden and acute. That speaks against chronic subdural hematoma. That is the only thing. Otherwise, yes, it's a possibility. That's why I'm keeping it.
Can we add migraine to the list?
Excellent.
Migraine
Excellent.
headache.
Excellent. Who is speaking?
Biza.
Beza, thank you so much. Beza, are you the one whom I met in Blackline?
No.
No? Okay. የኤምሳ ኦፊሻል እህታችን አለች። ቅድም ፒክቸሯን ስላየሁ። I'm sorry. Which university are you from?
MMC, Korea.
ኮሪያ። እሺ። እንኳን ደህና መጣሽ እህታችን። So
Thank you.
migraine headache is a very important differential diagnosis. Yes, but the only thing is, yeah, of course, sometimes some patients with migraine, they may have neurologic deficits and all that. But migraine, the only caveat or the only thing against migraine would be the presence of facial palsy and weakness of the right extremities. That's against it. And otherwise, it's a possibility. And she didn't complain of a headache. If it was a migraine headache, exacerbation or anything, she should tell you that she came with a headache plus weakness of extremities. Then you consider migraine. That makes it less likely. Shall I take it out, Beza?
Yeah, yes.
I think we can take it out. Any other differential diagnosis or shall I proceed? Tell me, guys. Okay, don't kill your time. Participate. I'm your brother. Don't be scared of me. And this is meant for you. If it is supposed to be a presentation, I can do the presentation myself and call it a day within 30, 45 minutes. That is not the intention. So let's participate, Argo. Please participate. Okay, guys? All right. So this is our differential diagnosis. We started with a long list. At least we have managed to make it down a little bit. So then now we will proceed. I will provide you with more information. But before I provide you more information, I want you to tell me what you are interested to know in this patient, okay? So let me give you her personal identification. Her name is Miss Wezero ZL, age is 66-year-old, and she is female, married, occupation, she's a businesswoman. So now this is her personal identifier. So what other important information do you want to know in the history? Now we are going to history of present illness, okay? Ask me questions, I will respond to you.
Non-chronic medical conditions.
Not really, but don't ask that first, right, Beza? Is it Beza speaking? Because the reason is,
Yes.
you are right, you can ask about it, but past medical, surgical history, family history, personal history, social histories, they are very relevant. They could be relevant when we're dealing, talking about history of present illness. But HPI starts by doing what? You have to know the basic principles when you are like doing HPI. So what do you focus on?
Time of weakness.
Yeah, so what is the main intention? Tell me the principle you should remember when you are like, dealing with HPI.
Chief
Elaborate the
complaint,
chief
then you
complaint.
characterize.
Thank you so much. Thank you so much. So you elaborate the chief complaint. You deal with the main problem first, okay? So ስለዚህ አሁን based on that principle, ask me questions. Try to elaborate the chief complaint. The chief complaint is right-sided body weakness, sudden onset, and associated with right-sided facial droop. So elaborate this, okay? Ask more questions related to this. Timing. So she presented after about an hour. She presented after about an hour of onset of these symptoms. So by the time she was at center, Yeah, go ahead, please.
Is it in the morning or in the afternoon?
It is just like, around noon.
Was she doing any relevant activity prior, or she just
No,
noticed?
she was just sitting in her shop, and she noticed weakness of her right-sided weakness, body weakness. And that happened about an hour ago.
Does
Any
she have any
abnormal body movement?
There was no abnormal body movement.
Was there loss of consciousness?
Yeah, so these are associated symptoms, guys. So these are associated symptoms you are asking me right now. You are right, you should ask as part of the HPI. You haven't finished characterizing the main complaint. Try to focus on the main complaint, okay? Right-sided body, I say right-sided body weakness. Do you want to know more about that? That's very important.
Was it maximum at onset?
What do you mean by that, doctor?
Did it gradually increase the weakness? Did it gradually increase, or is no change
Yes.
in that?
Yes, doctor. At the beginning, I started experiencing some numbness of my right arm, and it was feeling funny. And I was trying to focus on what I was doing at that time. And then I started experiencing some numbness in my leg as well. And then I was trying to get something, and my arm was like kind of weak. I was not able to even pick up my phone, and I tried to get up and look for somebody, and my right leg was also weak, and I couldn't really stand well. Okay, go ahead. Ask more questions. Does it happen previously? No, this is my first experience. Does a facial droop involve her scalp? What does that mean, doctor? So you are asking a layman. So I am not the patient. I am Miss WL. Remember that. So you are the intern at St. Paul Medical College Emergency Department. So you have to ask me in a way I would understand. I am a layman, a laywoman, okay? That's why I ask you and encourage you to participate by speaking up. Because, when you ask a question, I will give you a feedback, okay?
Seriously? Where? Here? When we go to shop, I'm gonna buy it for $20.
Huh? What did you say? What did you say?
And in the chat, there's any history of headache.
Oh, no, I don't have headache. Those are associated symptoms, guys. So try to elaborate the weakness first and the facial numbness first. And then once you are done with that, once you are satisfied with that information, then you can ask me associated symptoms, okay? So associated symptoms, aggravating factors, relieving factors, and associated symptoms are the ones. So stick to a basic principle. We are learning also at the same time basic principle of HPI construction. So you cannot jump here and there like a rabbit. There. No, that's not the way. You should be able to be very efficient in extracting important information from a patient. Okay. Go ahead.
Does it predominate on the upper extremities or the lower extremities?
Now, and I'm going to give you another information. Now, I am the patient, and I am not able to tell you more about it. So my language is becoming difficult for you to understand. What do you do? You are trying to elicit information, but I am not able to provide you more information. It looks like I am not getting what you are asking me, and it looks like I am not able to say something.
Resource limited.
Huh?
Are we in a resource limited setup?
No, I mean, wherever you are, you are trying to get an information, but I'm not able to provide you the information. Then what do you want to do? You want to get more information from this patient, right? Because that's very important to manage this patient. There are many things you have to know before you embark on something. So what do you do next?
Family? Is there family around?
Yes, there is family around. So I am her husband, so you can ask me questions, okay?
Okay.
So the patient is no more able to provide, relevant information. She's trying to say something, but you couldn't understand. And it looks like she's confused as well. So now you have to rely on me. I am the husband. Ask me questions, whatever questions you want to ask me. Aphasia. It looks like I may have aphasia, but I don't know what that aphasia is. So you have to, the Saling, if you are thinking of aphasia, ask me. I mean, ask the husband. Huh? And the weakness started in the arms, and then it involved the leg. It was gradual. Yes, doctor, initially she was struggling. She was trying to pick up her phone. She failed. And I was nearby. I came to assist her, and I was trying to move her to the next room. She was not able to stand up by herself. It looks like her right side of her leg seems a little bit buckling. So I am providing you this information. So go ahead and ask more questions. Sorry. So you want to ask more about the aphasia because now it is becoming relevant, right? So you can ask questions. So how do you ask questions about aphasia?
Is she unable to speak completely?
Yes, she was able to speak like about an hour ago. She was like, chatting with me, no issue. I was completely understanding her. But on the way to the hospital, some of the things she was saying was difficult for me to understand. And sometimes she was also struggling to find words, even common words. She even forgot, she was not even able to say, this is a phone. So she was struggling when we came here, and now, as you see, she's not able to really respond.
But was she able to understand commands? And
At the
what?
time, are you asking me about an hour ago? And about an hour ago, she was perfectly fine. She was at her job, no problem. We were conversing, there was no issue. Right now, she seems confused. I don't think she's under. Mute Argulan. Can you mute some of you guys?
You're
Like
the
if they're
host,
not.
sir. You're the host, so I have to mute
Okay.
her.
The problem is she can mute herself actually. I don't see who is I cannot really see who is speaking at this point. So if you are not speaking, try to mute it, okay? Whoever is speaking in the background. Okay, go ahead. Ask questions, guys. Don't take too much time. Don't take too much time. So speech, now you can go ahead and ask me about, associated symptoms now. Feel free to ask associated symptoms now. You get the point, right? The reason why I hold you there is because I want you to focus on the main presenting complaint, and then you branch out. Now you can talk about aggravating factors, relieving factors, if there is any. If there is none, I will say no. And then you can talk about associated symptoms, okay? Anything you want to ask.
History of trauma?
It's a no, she was at work. I told you already, doctor. She was sitting, she was working. There was no trauma at all. She was working in her office, in our shop.
Was there loss of consciousness?
She didn't lose consciousness, but when we came here, she seems a little bit confused to me because I was trying to give her some commands. She was not understanding. I was asking her where she is. She was kind of confused, but she didn't lose consciousness. And nausea, vomiting, there is no nausea and vomiting.
History of cough or bilateral leg swelling prior to the onset of symptoms?
She was 100% okay, doctor. And there was no symptom, no cough, no chest pain, nothing. She was okay, apparently. There was no fever, doctor.
Any
And there
abnormal
was
body movement?
no abnormal body movement. She was
History
fine.
of
She was
incontinence.
nothing. I mean, she was fine. I didn't check. I think you can check it later. But as far as I remember, no incontinence. And she didn't complain of any headache at all. And she never
Any
had any
history of
history of
rash?
headache. Huh?
Any history of rash, joint pain, or
No rash at all. She was perfectly fine, doctor, as far as I remember. Nothing at all.
There been any significant change in life? Anything
What
you'd
do
like
you,
to tell me?
what do you mean by that?
Any recent passing of relatives?
No, not
Any
really. Not
different
really. We
life
are
changes?
fine. Our family is fine. We are good. We are happily married, I presume.
Any personality changes
What do you mean by personality changes, doctor?
prior to the onset, like behavioral changes,
Or
or
like
any kind
becoming
of
angry or fighting or something like that, or what?
Yes, and
No,
change in behaviors.
no, she is fine. She's a very pleasant wife to me. We have been married for the past 30 years.
But you've been complaining of frequent headaches, maybe, or
No, no history
feelings
of
of
headache at
unwell.
all. No headache. She was perfectly fine. By the way,
Any
guys,
such
one thing I want to remind you, if you ask one question and if you continue repeatedly asking the same question, it will be offensive to the patient, and the patient would start, or the family starts looking at you. Is he listening to me? That kind of stuff. So try to avoid asking the same questions millions times. So be attentive. If somebody has asked it and I have responded, don't ask the same question, okay? Because they may assume that you are not listening. You have to be careful. And sometimes, like, if you ask a question twice, some people might say, I already told you about that, doctor. Then you have to apologize. I do that. Sometimes I get distracted and I ask the same question. I'm a human being. I do it. Then when they say that, then I don't want to offend them. And I say, oh, I apologize. Yes, you are right. You sure did. You have told me. I'm so sorry. I do that. Especially here, people are really, they can be cranky sometimes. Okay, go ahead.
history of sexually transmitted infections,
Like
or
what,
any
like what, doctor?
HIV or syphilis?
No, we are happily married. We are really, uh, what do you call that? We are, ምንድን ነው የሚባለው? ታማኝ. We are, what is that terminology? We are, የፈጣሪ ያለ. Anybody with a word?
Faithful?
Faithful.
Yeah, we are faithful to each other, I believe. Loyal, yeah, we are loyal to each other. And recently, a couple of years ago, she tested for some reason, and there was no HIV, nothing. And yeah,
Any kind of
no,
medications?
like
Is
what,
she on
doctor?
any, like
Yeah,
steroids?
no, she doesn't have any steroid use, but the only thing she takes is blood pressure medicine, and she takes also cholesterol medicine. That's it.
Okay. Is she adherent to her medication?
Yes, she's very compliant. She takes it religiously.
What's her BP range?
Sometimes it goes up, but for the majority, like, around 140 by 85, sometimes it can go up to 90, 140 by 90, 135 by 90, that kind of stuff. So sometimes she struggles, it goes up sometimes, but when she is more focused in her diets and all that, it's much better.
Did she complain about feeling her heart beating?
What do you mean? Is it something, the funny feeling in the chest, or is it the palpitation you are mentioning, doctor?
Yes, the palpitation.
No, no palpitation. Or you can also call it heart racing. Okay, heart racing is another important terminology. No, she does smoke. Yeah, she does smoke half packs of cigarettes.
Any recent sinus or dental infections or
No,
procedures?
no, she was. This is why I was telling you repeatedly. It's a very important question, but I was telling you she was apparently healthy, no issue. That means whatever you are asking me, most of the things you are asking me are going to be negative, right? So she was apparently
Okay.
healthy, nothing, she was fine, means most of the things are like not existing. So I appreciate you because you are trying to exclude differentials and you have to ask specifically those questions. I do appreciate it. That's fine to ask, but sometimes if they tell you she was apparently healthy, no health issue, nothing, then you can assume that, most of the things are negative. But if you think it's relevant, you can go ahead and still ask it, and I appreciate that you ask it.
Hello, doctor. Can we proceed to physical examination? I think based on our
Excellent.
timeline.
Excellent. Okay, good. You guys, you are running out of time, so if you are missing then, we will downgrade you based on performance. Okay. So let's see how much information you have managed to gather in the dedicated time. Okay. So let's see what she has. Thank you, Gamachu. Yeah. Enforce the law. Okay. She came with sudden onset of weakness on the right side. She was fine 30 minutes ago. You can say 1 hour ago because I said 1 hour. 60 minutes ago, let's say that. Before the onset of her symptoms, she is unable to move both her right upper and right lower extremities. She also complains of numbness. You didn't ask me about any sensory issues. I told you I feel numb, but you didn't elaborate. That's why I told you elaborate, okay? So she also complains of numbness. Where is the numbness? You have to ask her. Is it in the face? Is it in the upper extremity? Is it in the lower extremity? That is very relevant because even in terms of considering differential diagnosis, having sensory symptoms or not is very important. So you have to elaborate, okay? She also complains of numbness on the right side of her face. She had some word finding difficulty, okay? And her family could not understand what she was saying. I told you already. She was immediately brought to St. Paul emergency department, okay? And she is non-hypertensive patient. I told you about that. You didn't ask me what kind of medication she was using. She uses lisinopril 10 milligrams. So if patient can provide that information, you can ask them what type of medication, how much is the dose, how frequent, and the frequency. Always try to do that if your patient can provide that information. If they can't, they can't. And you can ask them to show you the container or the prescription or whatsoever is available. And she's on atorvastatin 40 milligram PO daily. Okay. And then the next important part is no nausea, vomiting, no headache, no orthopnea, PND, lower extremity swelling, no prior history of similar problems. So you asked me about palpitation, but you didn't ask further questions about, cardiac issues because somebody with a cardiac issue may present with a stroke. We'll talk about it later. So you have to talk about orthopnea, PND, lower extremity swelling. That is very important. That is very, very important. You should ask. Okay. No prior history of similar problems. Somebody has asked about it. That's beautiful. Okay, you did it. So you didn't ask me about GI symptoms. Somebody asked about whether a patient is taking anticoagulants or not. The answer is no. And if the patient has been taking any anticoagulation, you should ask about GI symptoms. What GI symptoms do you want to ask? You ask it about nausea, vomiting. That's very important because if a patient has nausea, vomiting, plus weakness of extremities, headache, that tells you about what?
Increased ICP.
Increased ICP. So it's very important to ask about presence or absence of nausea, vomiting, and headache. These three are present with weakness. Think of, be mindful, this this patient might have increased intracranial pressure, okay? No urinary complaints. And the other GI symptoms you can ask about is, things related to bleeding. You can ask them whether they have melena or hematochezia or whatever, especially if they're on blood thinners, okay? Good. So the reason why I'm rushing is because you have asked most of these questions, and our time for gathering information has ended. Okay, past medical history, you tried to ask about hypertension, yes, but important things you have missed. You didn't ask me about alcohol. That's very important. You didn't ask me about diabetes. That's very important because these are potential risk factors. The only two risk factors you have identified so far is hypertension, high cholesterol, and smoking. What about obesity, whatever, body habitus, body activity? Is the patient active? You should ask. You should ask. Are you active? Do you exercise? Those kind of informations are very important. Have you gained weight recently? Did you lose weight recently? What kind of food do you eat? Okay, diet and everything. These are relevant. So she had history of hypertension, 15 years on lisinopril, dyslipidemia, 10 years, atorvastatin, 20 milligram daily. I said 40 milligram. Please correct. It is 20 milligram. Okay, so you can change that information. I don't want to be contradicting each other. So it's 20 milligram daily. She is compliant with her medications. You have asked me about compliance. That's beautiful. Okay. And she doesn't have any diabetes or any health problems or any other chronic medical condition. No history of cancer. Nothing in the past medical history. And in the surgical history, is past surgical history important for this patient? Who wants to respond? is past surgical history important in this patient, guys?
Yes, especially if,
Yes, it is. Why is it important?
especially if it's recent surgery.
Beautiful, beautiful, excellent. Especially if it is a recent history. You know, the history of recent surgery by itself might have predisposed this patient to stroke, or if you are diagnosing something, let's say like, ischemic stroke, whatever, and we want to manage a patient in a certain way, that can positively or negatively impact your decision. Okay, so surgical history is very important, especially recent surgical history is very important. So you have to ask that. Okay, and what type of surgery? Was it brain surgery? Was it spinal surgery? Was it abdominal surgery? Was it thoracic surgery? Or was it something like, cutting a nail or something like that in the periphery? That also matters. Okay. Recent surgery, removal of a cancer in the face may not be as important as recent surgery in the brain or recent surgery in the spinal cord or recent surgery in the thorax or in the pelvis or in the abdomen. So what type and when was the surgery done and what was the extent of the surgery is also very important. Okay, we have to know that important information. Okay. Social history, she smokes half pack for 30 years, denies alcohol consumption, you missed alcohol, no recreational drug use. That is also very important because, like, one of the differential diagnoses is you haven't mentioned is what? One of the very important stroke differential diagnoses. What is that? Especially a patient who is confused, patient with weakness, a patient with dysarthria or speech difficulties. What is a good differential diagnosis? Huh? Alcohol, yes, alcohol intoxication, even though she was working and she hasn't been drinking. Alcohol intoxication, in general, intoxication, it could be due to alcohol, it could be due to other recreational drugs. Okay. So any other recreational drugs and intoxication of any sort, including alcohol, is relevant. So alcohol consumption, use of recreational drugs is very important. And anticoagulation history or treatment history is also very important. Actually, that's part of the medical history, so you can take it out, okay? It doesn't matter. We discussed about it already. That's very important, okay? So let's narrow our differential diagnosis. So I will paste it down, whatever differential diagnosis we have been mentioning up there. I will bring it here and then we'll narrow it down, okay? Which ones do you want to keep? Which ones do you want to remove? Oh, shit. I think, I don't know. Let me go back until you guys think about them. Let me go back and copy this like this. Uh-huh. Which ones do you want to keep? Which ones do you want to remove? So these were the list. This is the list we have. So let's narrow down. If you want to add a differential diagnosis based on the detailed information you have gathered, you can also ask, okay? You can also add.
I'd like to remove conversion disorder.
Conversion disorder, less likely, right? There was no such a strong risk factor for conversion disorder. Uh-huh. Huh?
Epidural.
Epidural hematoma, yes. There is no such risk factor for epidural hematoma. No history of trauma, right? What else?
Venous sinus thrombosis.
Venous sinus thrombosis is also very less likely, depending on the present. No headache, nothing, no associated periorbital cellulitis or anything like that. No infection in the HANT. No as such a significant risk factor, even though if there is a coagulation pathology, clotting disorders and all that, patients might present with, clotting there spontaneously, but it's less likely. What else do you want to exclude?
Dr. Dassalegn would like to add hypertensive encephalopathy.
Hypertensive encephalopathy, excellent. hypertensive encephalopathy. What is the problem with hypertensive encephalopathy? I mean, as a differential diagnosis, it can be if it is like, poorly controlled hypertension with hypertension urgency. It's not going to be hypertensive urgency, especially if the blood pressure is more than 180 by 110, I think. So that is a definition, right? 180 over 110, I guess, to qualify as, or to qualify as hypertensive urgency, but this is no more hypertensive urgency because there is brain injury, end organ damage, so it's going to be hypertensive emergency, not urgency. Okay, so hypertensive encephalopathy, hypertensive emergency, encephalopathy. So what is against that? So do they present with a focal lesion like this? Less likely, right? Cerebral vasculitis is also less likely, so we can remove cerebral vasculitis. This patient doesn't have, chronic issues. This is a first presentation. Less likely for a cerebral vasculitis to just present with sudden onset weakness and all that. So we can kick it out. Brain tumor also less likely. This lady was apparently healthy, no history of headache, nothing, no visual difficulties, no weakness at all in the past couple of days. So even if tumor bleeding can present acutely, she needs to have at least some symptoms, right? In the long term, in the long run. So brain tumor bleeding within the tumor is less likely, so we can kick it out. What about TIA, guys? Are we dealing with TIA, transient ischemic attack? Who is bold enough to answer this question? Are we dealing with TIA?
Yes, it can be TIA.
Okay, you say yes. Who is that? Beza is saying yes?
Yes.
Okay.
Patient's presentation is still within the 24-hour window. So
okay,
it counts.
do you guys agree? Beza is saying since duration is less than 24 hours, TIA can be our differential. Do you guys agree?
Yes.
Yes. Who would disagree?
If there's any evidence on imaging, it can't be TIA.
Who is speaking?
Salim.
Huh?
Salim.
Salim, where are you from? Like Ethiopia, but from which medical school?
MMC.
MMC. Minsuyang. I'm sorry. ይቅር በሉኝ if I butcher it. Korea Hospital, right? Myung Siang, right? Okay, medical school.
Yes.
Okay, sounds good. So, all right. So imaging, you need imaging to say whether there is TIA or not. Now, ያለችን ያለችው Salim. Who would disagree?
I'm going to go for agreement as well. But I'm going to go for agreement.
Agreement. Okay,
If
go
we
ahead.
If we use, I think, the ABCD scoring, she's both above 60. She has had the duration of symptoms. We've said it's been an hour, or now an hour plus as it's extending. And we have unilateral weakness. And her blood pressure is high as well.
Yes, her blood pressure is high. I mean, we can still keep it. We can still keep it, but basically TIA, the definition now it's changing, right? Do you know that the definition is changing? The definition of TIA is changing. So in the past, you are right. Most people say like, if the symptoms were lasting only for less than 24 hours, then it could be TIA. And then, just duration was the most important thing. If the duration was more than 24 hours, then most probably are dealing with a stroke than a TIA, transient ischemic attack. So now most people, Salem has a good point. She raised a good point. So there should be an evidence of tissue ischemia. Okay, that's very important. So more biologic definition. So you are talking in terms of a lesion, presence of a lesion within the brain parenchyma. There must be a lesion, an ischemic lesion in the brain, and the symptoms resolve within less than 24 hours. Okay, so if the symptoms have completely resolved and there is no evidence of ischemia and the necrosis within the brain parenchyma based on imaging, then most probably that is not TIA. Okay. So transient ischemic attack is still a possibility because she's still in that window. Who knows? After 5 hours, the symptoms may completely resolve, you know. But if I tell you, like, if it was more than 24 hours and she still has symptoms, TI would be out. Okay. So TI is still staying there. Sounds good. Do you want to keep anything? Subdural hematoma? Do you want to keep subdural hematoma still in the differential diagnosis?
No, it's less likely.
Less likely because of the reason I mentioned earlier, because especially chronic subdural hematoma, acute subdural hematoma, the mechanism is similar to epidural hematoma. Most of the time it's linked to acute trauma, but chronic subdural hematoma, the presentation is somehow different. So regrettably, I'm going to remove it. You may be surprised because patients may not at all complain about anything until they become aphasic. Some people may not notice the weakness in their body, or the weakness may not be remarkable. And you find out there is weakness when you do physical exam, but they come to you when they become aphasic. So in that case, subdural hematoma, even chronic subdural hematoma, could still be a differential diagnosis. So shall I keep it? Let me keep it. You get my point, right?
Yes.
My reasoning? Yeah, if you don't agree with my reasoning, challenge me, please, okay? Because I want to see your thought process, and I don't see it as a challenge. Don't worry, okay? I wouldn't be offended. The main purpose is just to make you discuss this kind of thing. So, what physical examinations do you want to do right now? And if you want to give a feedback, all of you, if you want to give a feedback to yourself, what feedback do you use to yourself? What feedback do you give to yourself in terms of your approach to this particular patient? What did you miss? And what things do you have to make sure that is not happening? Do you get my question?
No.
I know, I complicated it. So let me try to explain myself. So now, so far, you went ahead and did an extensive history taking and all that. But was there any other principle to be followed in this patient when you encounter this kind of patients before indulging into digging about the circumstances, asking about multiple questions and all that? Is there anything you would like to focus when you encounter a patient with such a kind of presentation? A little bit of confusion, weakness of extremities, weakness of, facial droop and all that. ABCD, that's excellent. So you have to focus on the ABCs of life. So what is A is the airway, make sure the airway is patent. B, breathing of the patient. C, circulation, whether circulation is fine or not, and then disabilities. This is very important when we are dealing with a patient with a stroke for many reasons, because sometimes patients with a stroke, they may be vomiting, they may be unable to protect the airway, their airway, they may be at an increased risk of aspiration, they may have bradypnea, they may not breathing well. Because of all these reasons, before you take long time dealing with history taking, doing physical exam, you have to make sure that the ABCD, at least the ABC is intact. You didn't do that. So you didn't tell me. At least I kept quiet for a reason until we reach this level. So you have to make sure that ABC of life is intact in this patient. If the patient is stable, talking to you, responding to your questions, that is fine. Indirectly, you have assessed ABCs. Now I am talking, right? I am conversing. I am engaging in a meaningful conversation. So for sure, whoever is engaging, dealing with me knows that my brain is working fine. My airway is working fine. It's intact. I'm breathing fine. That's why. Otherwise, if my airway is blocked, I wouldn't be engaging in a conversation, in a discussion like this. If I was breathing hard, I wouldn't be engaged in such a beautiful conversation with you guys. The same thing, if my circulation has collapsed, I wouldn't be engaging in a conversation with you. So if a patient is stable, well and good. You can skip, you can go ahead to your history taking. But if you think there is something is compromised, either the A or the B or the C, you have to take care of the ABCs first before you go ahead and do detailed history and physical exam. Do you get the point now?
Yes.
Okay, so now patient is stable. There is no problem with A, B, and C. What areas of examination do you want to focus? And why? Or don't read, okay? Challenge yourself, just, you know it. Vital signs. Before vital signs, always I try to remind you, before vital signs comes what?
The
General
general
appearance.
General appearance, don't forget that. So general appearance means when you come in, the nurse tells you there is a patient 65 years old, a female patient with weakness. You come into the examination room, you look at the patient, your eyes are inspecting the situation, and the patient is stable, she's sitting, then you are fine, general appearance. Patient is gasping, that means you have to really act. The patient is comatose, is not responding and fighting, aggressive, agitated, then you have to take an action. And then the ABC comes to picture at that time. Patient is struggling to breathe. That means airway is not good, B is not good. You never know. Patient is completely knocked out, collapsed. This all is a general appearance. So don't underestimate general appearance. So this lady was comfortable. She was not in respiratory distress, but she was kind of acutely sick looking, a little bit nervous and restless. Okay, this is her general appearance. Okay, what else do you want to do? Then the next one is vital signs. So the vital signs, most of the time, you know, if you are in good center, the paramedics or whoever is bringing this patient should be able to monitor her blood pressure, vitals, and everything, oxygen saturation. They will provide you with that information. If patient has been unstable along the way to the hospital, they have to resuscitate. If a patient was like, you know, not able to maintain the airway, gasping, whatever, they have to try to intubate the patient. They may end up intubating along the way if they are capable of doing that. Or if they are not able to do that, at least they will help the patient with bag breathing, and they will tell you to be ready and wait for them being ready to intubate the patient upon arrival to the ED. So that information is very important. So vital signs, she is basically, her blood pressure was significantly elevated. I don't remember exactly what that was. Let me tell you, it was 190 over 100. Okay, she fulfills the criteria for hypertensive urgency emergency. Okay, the other vital respiratory rate was 22 per minute, temperature was 37.1, saturation was 95%. We want to supplement oxygen to this patient. Do you want to supplement oxygen to this patient? Yes or no, guys? Don't kill time, please. Let's be fast. We have a lot to discuss. ስለዚህ ቶሎ ቶሎ በሉ. We are stuck in 14ኛ slide ላይ. So we have to be as fast as possible, okay? Do you want to give oxygen? Yes or no? Are you there, guys? You scare me sometimes.
What was her
Youth is not working.
saturation?
The saturation was 95%. Do you want to give oxygen?
No.
Yeah, the answer is no, because like, you know, she's maintaining her saturation. Why do you need to give her, oxygen? Do you give me oxygen now? My saturation is 96, 95. Do you give me oxygen? No. She can maintain her saturation by herself in room air, so no need. So stroke patients, like, you know, if there is saturation drops less than 90, whatever, if they don't have any chronic obstructive pulmonary disease like asthma, COPD, you have to supplement with oxygen and maintain their saturation well above 93, 94%, okay? Sounds good. So vital signs, what other systems do you want to examine? Just mention the systems, and then I will tell you the findings in those systems, okay?
The cardiovascular.
Cardiovascular. Why do you want to check the cardiovascular system? So guys, when you give me an answer, give me a full answer, okay? Cardiovascular because of this reason, and you will get 100% mark, okay?
Because one of our differentials is stroke, and a failing heart might result in an embolic stroke.
A failing heart. You see, when you speak up, you open an opportunity for discussion. Thank you so much for speaking up. So a failing heart means congestive heart failure, right? So how does congestive heart failure contribute to stroke? You said embolic. embolus.
Yes.
So a failing heart, why should it give you an embolus to the brain? So I am
Because of
giving you the chance to correct yourself. You are in the right track. You are right. Cardiovascular system is important. Cardiac pathology may predispose to stroke, but CHF doesn't result in embolic stroke, but it can cause something else.
because of stasis, wall stasis, it predisposes the patient for the development of thrombus inside the ventricles or inside the heart.
Excellent.
So that can embolize and result in stroke.
Beautiful. So now a failing heart with wall motion abnormality, a patient with wall motion abnormality, congestive heart failure, is prone to develop intraventricular thrombus that can go to the brain and result in embolic stroke, cardioembolic stroke. Beautiful. Thank you so much. I love that. Okay, cardio. So you are trying to see if there is any sign of CHF. CHF can also result in another form of ischemic stroke. What is that? Other than
Hypoperfusion.
hypoperfusion. So if the heart has failed, if there is cardiogenic shock, then there is going to be global brain hypoperfusion. So the third type of ischemic stroke is actually because of hypoperfusion. So then, global brain hypoperfusion can result can happen in a patient with congestive heart failure with cardiogenic shock. Beautiful, beautiful. Yes, so you have to examine the heart. What else can contribute to cardioembolic stroke?
Atrial fibrillation.
Atrial fibrillation, atrial flutter, any arrhythmia, atrial flutter, atrial fibrillation. They can result in left atrial appendage thrombus that can be thrown into the brain and they may present to you embolic stroke. Very beautiful. So you have to assess the pulse. Is the pulse regular? Is it irregular? Is it regularly irregular? Is it irregularly irregular? That is very important. What else do you want to do as part of the cardiovascular exam?
Into the vascular system. Assess
Vascular
pulses distally.
Beautiful. Assess peripheral pulses. And most importantly, which pulses do you want to check?
The carotid.
The carotid is beautiful. So you have to assess the carotid pulsation. You have to auscultate whether there is any carotid bruit or not. That tells you if there is any atherosclerotic lesion, big vessel thrombosis is one of the differential diagnoses. And you have to make sure that there is no narrowing of the major vessels going to the brain. So carotid pulsations, carotid bruit, and everything has to be checked as part of our evaluation. Peripheral vascular disease can give you a hint. Okay, if the pulses are absent in the lower extremity, that means the patient might have peripheral vascular disease or peripheral arterial disease. If they have a peripheral arterial disease, then they are also highly likely to have narrowing of the vessels going into the brain, be it external or be it the carotid, the common carotid, be it the internal carotid artery narrowing. Okay. Very beautiful. Okay, so peripheral pulses, cardiovascular examination, check for murmurs. Why do you check for murmurs?
Structural defects in the heart, like
Yes.
raised URST, can result in a paradoxical embolus
Excellent.
in the presence of a DVT.
Excellent. So somebody who has got embolus somewhere else, they can have right to left shunt at some point, and then they may develop this paradoxic stroke. Okay, that's number one. And number two, any valvular lesion suggestive of infective endocarditis with vegetations. It's not only blood clots. Sometimes vegetations can also be thrown into the brain and they can result in cardioembolic stroke. Okay, so check for vegetations, endocarditis, infective endocarditis can predispose patients to stroke, especially left-sided valves are involved with like aortic valve, mitral valve, and all that. So you have to check for murmurs and all that. Beautiful, beautiful. What other system do you want to examine? You jumped into cardiovascular. Before cardiovascular, there is HNTs, right? As part of the HNT examination, is there anything you want to do? You can also do it as part of neurologic exam, but you can also do it as part of the HNT examination, something which might be...
Ophthalmologic exam.
Ophthalmologic examination is very important. Yes, excellent. Does the patient have any periocular swelling, cellulitis, especially some of your differentials like dural venous sinus thrombosis and all that are associated with such infections. You have to do also fundus examination. You have to examine the fundus, okay? The fundus might give you some clues, okay? That's very important. Beautiful. I love it. Especially if a patient has like, visual defects and everything. Of course, that can be completed. Like I said, fundal exam can be neurologic exam, part of neurologic exam as well. So that's fine. As part of a cranial nerve evaluation, you can also examine some of the ocular functions later. Okay, that's fine as part of neurology exam. What other system do you want to examine?
Respiratory
Pupillary
system.
size. Beautiful. Pupillary size. Excellent. Yeah, pupillary size is very important. You may see pupillary dilatation for some reason. And that's relevant. Beautiful. I love it. That can also be part of your cranial nerve examination, though. Either way, that's fine. Okay. What else?
Bleeding gums or epistaxis.
Excellent. So you want to examine the gums, whatever, for bleeding tendency, especially if a patient is on having some sort of, blood disorders, or if they have been taking any anticoagulations and all that. Okay. What else do you want to check? What other system?
Lymphoglandular.
Lymphoglandular, why?
So this patient is old, and if we find any swelling or enlargements of the lymph node, might suspect the malignancies.
Less likely, less likely. You don't expect lymph node enlargement with brain tumors, right? And we think brain tumor is less likely in this patient. Lymphoglandular system may not be relevant. For the sake of completeness, of course, we have to examine every system, but it may not be directly related to the stroke or whatever differential you are considering at this point. Any other system which
Respiratory
might be...
system.
A respiratory system is very important. You have to assess, especially I told you, ABC. So is the patient breathing well? Did the patient aspirate? That is very important. A patient with a stroke, they are highly, highly at risk for aspiration. So you want to check the lungs for aspiration. You want to check patient for respiratory status. You check the saturation and all that. Sometimes, these patients may have bradypnea. They may not the centrally depressed breathing. Their breathing matter pattern might be affected, so you have to examine the lungs and the breathing system as well. Okay, what else do you want to examine?
If there are crackles suggesting heart failure.
Yes, cardiovascular and pulmonary, exactly. What other system do you want to examine?
Integumentary system.
Integumentary system, excellent. Why do you want to examine the integumentary system?
If there is any skin or mucosal bleeding features, we can.
Yes, and also some evidence is suggestive of subacute bacterial endocarditis, these Janeway lesions, subungual bleeding, this kind of things, which might suggest, infective endocarditis and all that may be seen in the integumentary system, and you can check for that. Any rashes and everything, okay? Good. Yeah, so that is beautiful. So general appearance, acutely sick looking, she's anxious. You have to check ABC of life. Don't forget that. Vital signs 190, I told you. HNT, fundus exam, don't forget. CVS, you can talk about murmur or absence or extremity swelling, peripheral pulses, very important. Skin signs of endocarditis. Cholesterol emboli, people with cholesterol emboli may have some features. It may be difficult to appreciate in dark-skinned individuals, but in the white population, those things might be apparent. CNS examination findings. Then what other system? Okay, we didn't finish. So what is the other most important system, and what are the components of that examination?
Musculoskeletal system.
Why musculoskeletal system?
Sign of DVT.
Sign of DVT, yes. What else?
We can do the ankle brachial index.
Yeah, so that is part of actually cardiovascular examination now. And that helps you exclude whether there is peripheral arterial disease or not. If the ankle brachial index is less than 0.9, if I remember correctly, then that would suggest peripheral arterial disease. Okay, you can do that as part of your work in cardiovascular examination. But what is the last most important system? Musculoskeletal system, you want to exclude joint abnormalities and all that because we are talking about weakness of extremities. So is it related to joints? Is there any deformity, anything like that? in the extremities, that's very important. So you can also kind of do it. So neurologic examination, what are the components? The first one is cranial nerve. Yes, cranial nerve. We have to examine the cranial nerves. What else?
Mental status.
Yeah, excellent. Before the cranial nerve is the mental status. So how do you assess mental status of the patient?
Was a GCS scale and their orientation to time, place, person, and
Yes, so you can ask them about their orientation, if they are conversing, if you are like, if they can respond to your questions, of course. But if a patient is confused, if a patient has altered mental status, the first thing you should do is calculating the Glasgow Coma Scale. So Glasgow Coma Scale, you know about it. I'm not going to discuss it in detail. Motor, it's scored out of verbal stimuli out of 5, right? And best motor, no. Eye opening is 4, right? Correct,
Yes.
Arvid. Eye opening is 4, verbal is 5, and base motor is 6. Am I correct?
Yes.
Yes.
So it becomes 15, 15 Yonan. So you have to calculate the Glasgow Coma Scale. That is very important because if the Glasgow Coma Scale of your patient is very low, especially less than 8, that means they may not be able to protect their airway, and they may not be able to support their respiratory system. So you have to go ahead without any question. You have to go ahead and intubate these patients right away before killing any time. Okay. Don't waste time asking questions, whatever. You just intubate the patient, secure the airway, and then you can talk to the family about what happened and gather more information. Okay? So Glasgow Coma Scale is very important. If in this patient, Glasgow Coma Scale was 15 out of 15. So then the next thing is to ask her about important questions about her orientation. So you can ask her to see if she's oriented to time, place, and person. So it is difficult to assess her orientation in this particular patient because her language was affected. So she's not understanding our questions, and we are not understanding what she's trying to say. So it will be very tough to assess our orientation, so you can jump it. And Glasgow Coma Scale, like I said, was 15 out of 15. Okay. What else do you want to assess? Somebody said
Motor
says
examination.
motor examination and sensor examination and cranial nerve examination. So motor examination has its own components. Who would like to remind me the components of motor examination?
there is bulk.
Yeah, you can talk about muscle bulk. So like, if there is any atrophy, that tells you chronicity or acuity.
Chronic.
Most probably chronic. Plus, if there is atrophy, is it telling you upper motor neuron lesion or lower motor neuron lesion?
Lower motor.
Most of the time, lower motor neuron lesion. Excellent. Okay, so the bulk. Okay, what else? So you have to compare. So right side has to be compared with the left side. Yes, go ahead.
Positioning.
Positioning, posturing, you means the posture of the
Yeah.
patient. Yeah, so posturing. So there are cerebral postures or decortications and decerebrations, right? So I don't exactly remember them. I am sorry. I don't have recent memory, but you can always refer about that. Okay, decorticate and what is the other one? Decorticate and decerebrate. Yeah, I think decortication is like this, right? They are hyperextending extremities, that I guess, this decortication. And the decerebration, that helps you to localize the lesion as well. Okay, decortications, decorticate or decerebration, decerebrate. I don't even remember the wording. So just read about them, okay? What does it mean? What is its significance? Read about them. That's going to be your assignment. And I will refer it next time. I'll ask you guys. And posturing, what else?
Spontaneous or
Posturing is not as such a motor part of motor examination. So bulk, what else?
spontaneous and
The tone. The
when
tone,
the
yes. Yes, tone. So if I tell you she has increased tone, is it telling you upper motor neural lesion or lower motor neural lesion?
Upper motor.
Most importantly, upper motor neural lesion. Okay, so the tone is important. She has increased tone. What else?
strength.
Reflex.
Huh?
Strength.
Reflex.
The strength is or power, right? So you can assess the power. So as part of powers, I'm going to tell you that right upper extremity 0 out of 5, right lower extremity 0 out of 5, and left upper, left lower extremity, they are 5 out of 5, okay? Sometimes it may be difficult to assess, especially if the patient is not understanding your command. If they are not understanding what you are telling them, then they may not do it. And in that case, it may be very difficult to assess the power and sensory function. And what else is missing in terms of motor examination?
Reflex.
Yes, reflex is one of them, and the other one is fasciculation, okay? Presence or absence of fasciculation. So if I tell you there is no fasciculation, does it favor upper motor or lower motor neural lesion?
Lower motor.
Upper motor neural lesion. If I said if there is no fasciculation, if there is fasciculation, it favors what?
Lower motor.
Lower
If there is
motor.
fasciculation, lower motor. If there is no fasciculation, upper motor.
Yes, what I asked was there is no fasciculation, and that favors upper motor neural lesion compared to lower motor neural lesion. She has increased tone, power is 0 in the right upper and lower extremity. Okay, very good. And sensory, it may be challenging because this patient is not really understanding what we are trying to say. In that case, she may not be able to tell you whether she has sensation or not, her sensation is intact or not. At least if they have a motor aphasia, they cannot talk, but they can understand. In that case, if they understand your command, you can at least show them to say thumbs up if they feel you. So when you touch them, they can say this if they can understand your command. But sometimes it may be very difficult to assess sensory function in a patient who is not really understanding with aphasia, especially global aphasia. Okay, that's very important. Sounds good. Cranial nerve. Which cranial nerve is commonly affected and which ones do you want to check? Almost every cranial nerve has to be checked, right? Okay. So which ones are more relevant and which ones are the ones which we focus most of the time?
Facial nerve.
Facial nerve. So what kind of facial nerve? I told you in the history, especially this is relevant for this patient because she was complaining of numbness and weakness, facial droop in the right side of the face. So what kind of facial palsy do you expect in this patient? Because facial palsy can be two types, right?
Central.
Yeah, so infranicular and supranicular, right? So which kind are you anticipating in this patient?
Supranicular.
Supranicular. So what kind of facial nerve function affection do you expect in this patient?
Both motor and sensory.
And both can be affected, both sensation as well as motor can be affected, but do you expect, what is the basic difference between supranicular and infranicular facial palsy? That's what I'm trying to ask.
The area involved.
The area involved, part of the face involved, right? So what do you expect in this case?
If it's supranicular, it's both the upper part and the lower part of the face. And if
Do
it's
you guys
infranicular,
agree? Do you guys agree?
If supranicular, it
we
will
have
involve the lower
forehead
part.
sparing.
Yes, so I mean it's actually the opposite. If it is supranicular, you expect only the lower half of the face to be involved. So you will have facial droop like this. You see? And the nasolabial fold will be absent. You know the nasolabial fold, right? You see this fold here? Hmm?
Yes.
So that will be gone like this. So it will be gone. The face will be disfigured and the lower half would be affected. So when you check, for example, you can still see the creases and everything. The face, the upper part of the face is not affected. They will be able to close their eyes and they may not have difficulty closing their eyes. Whereas if you have infranicular facial palsy, like a patient with Bell's palsy, in that case, both the entire face in that particular side is affected and they will not be able to close their eyes completely like this and they cannot keep it open and all that. So you should know how to examine the cranial nerves. So what you do is you ask the patient to close their eyes and ask them to close tight and you try to open them and you try to compare both sides. And sometimes, there may be an overlap. You never know if it is an extensive lesion. And the other thing you should ask them is to smile for you. بس زين ديلو. During that time, you can assess the nasolabial folds and the symmetry of the nasolabial folds. And then you ask them to puff their cheek like this. And you push both sides. And you compare the strengths. And the other thing is you have to ask them to widely open their mouth and ask them to stick out their tongue. That's also very important. Which nerve is affected most of the time?
Cranial nerve.
ምላስ የሚያንቀሳቅሰው ማን ነው?
12.
Cranial nerve 12.
12 right? ሃይፖግሎሳል ነው የሚባለው። ማን ነው ስሙ?
Yes, hypoglossal nerve.
The hypoglossal nerve. So where do you expect the tongue to deviate? Here, right corner. Is it like this or like this? Yeah, go ahead. መመለስ ይቻላል. Whoever is like a እጁን raise ያደረገ ሰው.
To the same side of the lesion.
To the same side of the lesion, because like, you know, the muscles which are affected are like in the right side. ስለዚህ the left side is strong. The left side of the tongue is strong. The muscles in the left side are strong. They push the tongue towards the lesion as if the dog is trying to lick the wound. You are just there, the tongue is deviating to the affected side. You may not see it all the time. The other cranial nerve examination is just examination of which cranial nerve. እነዚህ ሾልደርን እንደሚያደርጉት እነማን ናቸው?
Accessory nerve.
The accessory. Which one was it? 11 ነበረ?
Yes.
እና እንደዚህ ሾልደር ሽረግ ማድረግ እና turning phase right and left, that's very important. You will have to assess that one as well. So at least the cranial nerve completely you have to assess. And the vision, like I said, you can also check for visual acuity and all that. And you can also check whether there is, you know, clonus or not. Clonus ነው ምንድነው የሚባለው? ምንድነው የሚባለው? Nystagmus, whether there is nystagmus or not. And you check for reflexes like, you know, corneal reflex, you check for pupillary reflex and all that. Okay, so as part of your cranial nerve examination, check for cranial ምንድነው የሚባለው? corneal reflex, check for pupillary reflexes and all that. Okay, who is raising the hand? You can speak up, that's fine. You can unmute yourself and talk. Somebody is raising hand. እኔ ነኝ raise ያደረኩት? I don't know. Lower hand. I think I am the one. I'm sorry. Good. So are you guys good? Are you happy with the examination part? We are taking a long time because this is what is meant by bedside presentation, right? So are you guys happy? Or are we taking too much time?
Good.
It's good. Okay. I don't be እንትን መፍታት ማን ነው እንትና የት ሄደ ወንድሜ? ገመቹ የት ሄደ?
I'm in charge.
You are in charge. Excellent. So be mindful of time. Okay. Give me a heads up if I'm taking a long time. Last time I get a feedback about, you know, giving emphasis to physical examinations. That's why I took time and I tried to demonstrate something. And deep tendon reflex, we forgot about it. So how do you check for deep tendon reflexes and where do you check for deep tendon reflexes? And in fact, motor examination, by the way, if you want to be very thorough, you have to examine each muscle group. Now, just I told you, like, you know, gross examination of the motor. That's what we do. We are not neurologists. But neurologists do examine each muscle group. Okay, extensors, flexors. Okay, they assess the biceps group. They assess the triceps. All these things, you know, they do a very detailed and thorough examination. I'm not a neurologist, so if I know the basics, that's enough. If you know the basics, that's enough. When you become a neurologist, you can be as detailed as they are. Okay. So deep tendon reflexes, at least you should know at least the main places we check around here. We hold the biceps tendon here in the cubital fossa with our thumb, and then we hit our thumb. Okay. With a hammer, I hit my thumb here. And then I see whether there is any contraction or not here. And you try to see the effect, you know, pronation of the hand like this. Pronation at the wrist can be seen if it is brisk. And you can also look at the biceps. And you can also hit in the back and try to see a contraction. So you have to expose the muscle group so that you will be able to see if it is reacting or not when you are like, using a hammer. And in the in the hand also, you put your hand, your thumb again over just above the wrist, and then, you hit your thumb and see if this group of muscles here in the forearm are contracting or not. Okay, that's also very important. And the other thing is in the lower extremity, you have to check at the knee and also at the ankle. Okay. So how do you grade deep tendon reflexes? Okay, let me tell you, CNS Glasgow Coma Scale was 15, power 0 out of 5. I told you increase the tone, sensory, reduce sensation in the right side of the body, no sensory level. Deep tendon reflex was brisk or exaggerated, +3 in the right side. Plantar reflex, Babinski present in the right foot. What is Babinski? How do you check for Babinski?
It's also known as the plantar reflex.
A plantar reflex. Let's assume that this is my foot. So how do you do it? This is a medial aspect. This is a medial aspect. This is a lateral aspect. So how do you do it?
We would like to run not a very sharp object, but pointed object over the lateral aspect of the plantar.
Excellent, my dear. That's how you do it.
Towards the median.
That's how you do it, right? You come like this towards the thumb, towards the big toe, right? So this is a lateral aspect, guys. So you stroke along the lateral aspect and come medially like this. You make a curve like this. And during that time, if Babinski is present, what happens?
There's fanning of the toes. That's where the upward going of the big toe.
There could be fanning of the toes, and then there will be an upgoing or dorsiflexion. Because the foot, this part of the foot, the upper part of the foot is the dorsal aspect. Dorsiflexion. This one, the plantar aspect, is also called ventral aspect. So dorsiflexion of the big toe, and so there could be fanning. So the mechanism is just, this lateral aspect of your foot is supplied by which nerve level? Which dermatome supplies it? Remember,
S1.
I am a surgeon, so I love anatomy, okay? Huh? S1, excellent. It's S1. So then the information is going up to the level of S1. So if you have an intact corticospinal tract, this information shouldn't be disseminated above the level of S1. But if somebody has a lesion in the corticospinal tract, it could be due to CNS lesion or it could be spinal lesion affecting the corticospinal tract. This information, which is carried by the S1, could advance to the level of L5 and L4. That is the reason why patients would have this upward dorsiflexion of the big toe, because those muscles which are supplied by L4, L5 would get information and they would do this. They would extend, dorsiflex. You get the mechanism, that's how it happens, and the corticospinal tract is affected. It can be affected in patients with a stroke. It may not be present in all stroke patients, though. It's not a rule. So most of the time it tells you that there is involvement of the corticospinal tract. That's what it means. And plantar reflex Babinski present speech, there is dysarthria, global aphasia. What is global aphasia? How do you describe it? She had dysarthria when she came in. Dysarthria means speech difficulty, slurred speech. She's trying to tell something, but it's slurred. It's slurred. It's affected. You can't understand it, or it's very hard to understand it. But in global aphasia, what happens?
The patient is unable to understand as well as speak.
Yes, they are not able to understand. They are not able to speak. So they are mute 100%. They don't respond to you. They are confused. They don't understand you, and they don't know what to say. Okay, they are completely mute. So visual field, she has left gaze preference and right homonymous hemianopia. What is homonymous hemianopia? What is homonymous hemianopia?
We can see the half of the visual field.
Excellent. have a preference to one of the visual fields. There are like, right side of your visual field, left side. So right side homonymous hemianopsia means the patient doesn't look in the right half of her right eye, in the right visual field of her left eye as well. So they completely ignore the right side. And sometimes, like, there is food, they eat only the one which they can in the left side. They completely ignore the right side. You give them a watch, or you ask them to draw a watch, maybe they will be, drawing the left half of the watch, and they ignore the right one. And the right side of your vision is controlled by the left hemisphere. So if there is a lesion in the left side, that's why you get right-sided homonymous hemianopsia. If the right side is affected, you will have left side homonymous hemianopsia. And the NIH, the stroke scale is 22. What is the NIH stroke scale, guys? Have you ever heard of this one? Have you ever heard of NIH? NIH means National Institute of Health ይባላል. It's a very big research center. I think it's federally funded. It's a very big institution, a prestigious institution in the US. So NIH stroke scale is 22. So what is that scale? Have you ever heard of that? Not
It
really?
quantifies stroke severity.
Yeah, it quantifies, stroke severity. There are different scoring mechanisms, but, the NIH severity score is more popular because, it's well studied. Most people use it. And it is a study which was associated with, therapy with tissue plasminogen activator, or like, what do you call it? ምንድን ነው የሚባለው? What is that terminology? Tell me the term. So I will remember it when I talk about it later. So it is well studied, especially with treatment and all that, in association with treatment. That is the reason why it's, commonly used. It's 22. So it is severe or is mild stroke when you see the value is 22. So it is severe because I will talk about it later. NIH score, the higher the number, the more severe the disease. Okay. So there are about 11 parameters. They have their own scoring mechanism. So if it is less than 4, it's mild. 4 to 15, 5 to 15 is moderate to severe, and 15 to 20 is severe. And then more than 21 is very severe. Okay, so that tells you in terms of prognosis as well. The higher the number, the poorer the prognosis, the poorer the prognosis. So deep tendon reflex grading, I have told you deep tendon 0 is absent, 1 is diminished, 2 is average or normal, 3 is exaggerated or brisk, but there is no clonus. That is what differentiates it with clonus. Do you know how to check clonus? Have you ever seen a patient with clonus? Have you ever seen a patient with clonus? I remember a funny story when we were medical students. One of our friends was asked to demonstrate how to do a clonus. And this guy went to the front, and you know what he did? He brought out his hammer. Will you be laughing or you will appreciate it? hammer አወጣ ክሎነስ ዲሞንስትሬት አድርግ ሲባል is he right?
No.
Just the hammer.
Yeah, he just
Just
brought
the
out.
hammer.
He was confused, he doesn't know what to do. So the professor said, I'm not going to tell you his name. By the way, he is now a critical care fellow in Harvard, Brigham Women's Hospital right now. So, so that doesn't determine your confusion in medical school, doesn't determine your fate. Okay, so you are still good. So this guy, he went out and then he was about to bring out his hammer from his pillow, ምንድን ነው የሚባለው, from his pocket, and we were laughing. የተወሰነው እናውቅ ነበር ክሎነስ እንዴት እንደሆነ እና ያው የተማሪ ነገር ታውቆ የለ at that age you like enjoying when your friend makes a mistake. People were laughing. So how do you do a clonus? Anybody who has seen a clonus before?
Never
Yes.
seen clonus, doctor, honestly.
You have
I've never
seen
had a
clonus.
patient with clonus, but in theory, I think we quickly, briskly try to initiate movement to the extremity.
Where?
To the extremity. For
How
example,
do you initiate movement?
we hold, let's say,
no.
No. For example, we hold the 5 toes and we pull down and quickly pick up.
Okay.
Brisk movement. And then if
Brisk
there's
movement.
flapping,
like this.
we say
ልክ
there's...
ጣቱን እንደዚህ ይዘህ እንዲህ ስታደርገው እንዲህ ካለ
Yes.
ተርገበገበ። Okay, do you guys agree? He tried.
That's
At least he tried. Oh, asterexis is something else. እሱ እንደዚህ ነው። ልክ ትራፊክ እንደምታቆሙ ነው የምንላቸው። ልክ ትራፊክ ሰው እንደሚያስቆመው እንደዚህ በሉና ፋናውት አድርጋችሁ ወጥራችሁ ያዙ ነው የምንለው። ያኔ እንዲህ ከተርገበገበ ፍላፒንግ ትሪመር ይባላል። That is something else. You check that in some other situation like hepatic encephalopathy and others. No, I am talking about clonus and he's talking about ቱውን ይዘን እንዲህ ብሪስክ ስናደርገው እንዲህ ይርገበገባሉ እያለ ነው ሌሮይ ግን I love your idea. Let me show you how to do a clonus. Do you see my እንትን ጉልበቴ ይታያችኋል?
Yes.
ጉልበቴ ይታያል አይደል? የፔሸንቱን ጉልበት እዚህ ጋር ትይዙና ይሄ እንትኑ ማለት ነው እዚች ፓቴላው ያለበት ጋር እሱ ጋር ትይዙና እንደዚህ ወደ ላይ ነው ሙቭ የምታረጉት። ልክ እንዳለው ያዝ አድርጋችሁ ወደፊት ሙቭ ስታረጉ እዛ ጋር ብሪስክ ሙቭመንት ካለ፣ ሁለተኛው ደግሞ ፉቱን እንደዚህ ትይዙና ፍሌክስ አድርጋችሁ አደኒ ኤንድ አደ ሂፕ እንደዚህ ይዛችሁ ዶርሲ ፍሌክስ ስታረጉት እንደዚህ ዶርሲ ፍሌክስ አድርጋችሁ መያዝ ነው። ያኔ እንዲህ ይርገበገባል እጃችሁ ላይ ማለት ነው እግሩ። ግልጽ ነው? ቪዲዮ ፈልጉና እዩ። ክሎነስ በሉና ዩቲዩብ ላይ ያኔ ድሮ በደጉ ዘመን ማን ያሳየናል? ዩቲዩብ የለ፣ ኢንተርኔት አክሰስ የለ፣ በስተኛ ላይ ነው የምናየው። አሁን ግን you can literally Google for any physical examination on YouTube and you can see it. Okay, so just Google for clonus and see what it means. እኔም አሳይቻችኋለሁ ተገለባብጬም ቢሆን ይሄ ነው እንግዲህ NIH ስኮር ማለት ማክሲመሙ 42 ነው እንዳልኳችሁ ወደ 11 ናቸው። 1 2 3 4 5 6 7 8 9 10 11 12 13 14 it looks like it is 14 parameters እና ስኮር አድርጋችሁ ማክሲመም 42 ነው። ይሄው እዚህ ካቴጎሪው አለ ለዛም ፎር ጉድ ፕሮግኖሲስ ከ4 እስከ 20 ማይልድ ቱ ሞደሬት እና ያው እንግዲህ አይዲያል ቱ ቲፒኤ ይላል ኖት አይዲያል ግን ለቲፒኤ irrespective of severity, TPA can be given. By the way, we'll talk about it when we talk about management. So this information here might be a little bit misleading. Anyway, these are the components, okay? The other thing which we haven't done is like, drifting. So እንደዚህ ስታረጉት ድሪፍት ያደርጋል ይወድቃል። ዊክነስ ካለ ራይት ሳይዱ ድሪፍት ያደርጋል። ይሄም እዚህም ላይ as part of the NIH scoring system you have to check for drifting. That's also part of your motor examination ለማለት ነው. The other thing which we haven't included in the physical examination is gait. So patient to መራመድ የሚችል ከሆነ መንቀሳቀስ የሚችል ከሆነ you can also assess for the gait of the patient and see what kind of gait the patient has. Okay? እና NIH ስኮር ይሄው ካቴጎሪው እዚሁ ላይ አለላችሁ 0 no stroke symptoms 1 to 4 minor stroke 5 to 15 moderate 16 to 20 moderate to severe and 21 to 42 is severe stroke. Okay, this is at least how you categorize patients based on, and that dictates the prognosis of the patient actually, depending on the severity. And you can read about this one, I just added these slides for your reference, okay, so that you understand better, because NIH stroke scale calculation could be sometimes challenging, especially if a patient has previous weakness, if patient is comatose, if a patient is, already intubated and all that, it may be difficult to assess it. And there is a very important rule when you are calculating NIH score what you see, not what you think. Score the first response, not the best response, except for best language. And don't coach the patient. You don't have to coach, okay? Just do it. And there are trained nurses here in the US, so they calculate NIH stroke score right away. when a patient with suspected stroke comes, they go ahead and calculate NIHSS score right away. That's very important. And here, hospitals use it for reimbursement and everything. If you are dealing with a patient with a very severe stroke, the reimbursement you get would be higher because you dealt with a very complicated patient and all that. Okay, so there is a lot of reason and drama why they are using NIH score in the US. So aphasia also, just as a reference, I have added a couple of slides. I'm not going to talk much. So trouble speaking clearly, trouble understanding speech, trouble writing, trouble understanding written words, trouble remembering words, trouble remembering object names. These are the kinds of aphasia patients may have. It's a spectrum, so you have to assess whether these things are present in your patient or not when you do the physical examination. And also when you are taking history, you can ask about those informations. Broca's aphasia, you know what it is. So Broca's aphasia is motor aphasia. This is a Broca area. So it's found in the frontal lobe. This is a Broca's. If it is involved, then you will have motor aphasia. So the Wernicke area is the sensory, it's in the temporal lobe. You can see this is a temporal lobe, and it affects the sensory or comprehension part of language. So if only this is affected, it's going to be sensory aphasia. So patient is not understanding what you are telling them, but they are talkative and they talk a lot, but the words they tell you are haphazard and it doesn't make sense. And they don't know whether they make sense or not. They talk. It's nonsense. And they expect you to understand them because they have no insight that they are not making sense. In Broca's aphasia, they do understand you. If it is pure motor aphasia, they do understand you. It's also called expressive aphasia. They cannot express it. They cannot express their feeling. They know what to say. They cannot ፕሮዲውስ ወርድስ ኦኬ መናገር ነው የማይችሉት። ያውቃሉ፣ ይሰማሉ፣ ይረዳሉ። ማለት የሚፈልጉት ነገር አሉ። they have difficulty in finding the appropriate word and they have a difficulty in speaking out. So it could be very frustrating to the patient. They will be angry. They will be mad. Okay. So sometimes በዛ ምክንያት react ቢያደርጉ don't judge them. Okay. It's a very frustrating situation. And sometimes lesions can also involve the arcuate fasciculus, which is a conduction aphasia. So there are different types of aphasias. It's a spectrum. But if you remember Wernicke and Broca's aphasia, that's very nice. Brodmann's area 44-45. This one is Brodmann's area 22. Okay. This is expressive aphasia. This is a receptive aphasia. They don't receive the information well. They can't comprehend if it is like, Wernicke aphasia. Okay. Yeah, you have to remember these things. It's clinically important. It's relevant. When it is global, that means an extensive area of the brain is affected. So both sensory as well as motor components of speech are gone. So it's going to be very difficult for the patient to understand anything. Okay. I thought it is important. So receptive aphasia, you can read about it. It's also called fluent aphasia. They talk too much and they are very fluent, but they don't make sense because the words, they don't even have an order. Oh, I ate a lion in the cage was seeing his dad. You see, it doesn't make sense. They talk too much. A lot of words are coming out, but it doesn't make sense at all. Do you have any question, guys? Global aphasia, you can see a very big area of the brain is affected. So they are literally mute. They cannot understand. They cannot say anything. So it's very, very frustrating, like that of our patient. Sounds good. So let's narrow our differential diagnosis. Do you want to narrow differential diagnosis? It's very difficult now, right? So what do you think is going on in this patient? We have few differential diagnoses. So what is going on? Subdural hematoma, is it possible? TIA and stroke are still possible, right?
Yes.
Hypertensive emergency encephalopathy, less likely. Encephalopathy, hypertensive encephalopathy, most of the time, it involves the occipital region and all that visual abnormalities, headache and everything would be there. That is absent, so hypertensive emergency can be excluded, I guess, in the differential diagnosis. Which one do you want to remove further? ኧረ እናንተ ኩራተኛ ልጆች የሆነ ነገር በምታዩ
TIA and stroke.
Yeah,
Still
TIA
valid.
and stroke. Yeah, they are still valid. Subdural hematoma still possibility now. Imaging እስክናመጣ ድረስ እናቆየው።
እሺ
Okay, investigation ቶሎ ቶሎ ንገሩኝ። I give you 1 minute. ዝም ብላችሁ ደርድሩት።
non contrast CT.
I will kill you. ቤዛ ነሽ? ቢ ሲስተማቲክ ከሲምፕል ጀምሪ ከዛ በኋላ ወደ ኮምፕሌክስ ሂጂ። ልክ ነሽ፣ ትክክል ነሽ። ናን ኮንትራስቲቲ ቶሎ ጊዜ መፍጀት ስለማትፈልጊ ነው። ግን while you are resuscitating your patient you can take samples። ገባሽ አይደል? መልታይ ታስክ ታደርጊያለሽ። አንቺ ሂስትሪ አሰስ እያደረግሽ ፊዚካል ስትሰሪ ነርሶችሽ ሳምፕል መውሰድ ስለሚችሉ በሚለው በአይዲያል ሴታፕ እንሄድና ከቤዚክ ጀምረሽ አድቫንስ አድርጊልኝ to be thorough and to be systematic.
Baseline investigations like CBC.
Yes, CBC, BMP, liver function test, renal function test, you can do that. Okay, what else? There is no abnormality. Huh?
RBS.
RBS, random blood sugar, I love you. So, ምክንያቱም ምንድነው? A patient who is confused, patient with weakness and everything, they may come with hypoglycemia. So one of the differential diagnoses, especially if a patient has come with altered mental status, I should have made this case as altered mental status. I missed that opportunity. I'm bad. So I should have made it altered mental status ቢኖረው ጥሩ ነበረ። ምክንያቱም your differential diagnosis should be multiple. So stroke ብቻ ሳይሆን ሌላም ነገር ታስባላችሁ. So let's assume this patient has some component of altered mental status. So hypoglycemia is one possibility. Rule out that by doing random blood sugar. Excellent. What else do you want to do?
Coagulation profile.
Coagulation profile is very important. PT, PTT, INR is very important. ምክንያቱም our treatment could be giving TPA, right? So you have to know whether the patient has bleeding tendency or not. The other thing is you never know. This patient might have ingested something እና INR ከፍ ብሎ bleed አድርጋ ሊሆን ይችላል. So you want to do PT, PTT, INR. Okay. What else?
Electrolytes.
Electrolytes you can check. They are all normal in this patient. Okay. Random blood sugar was also normal.
ECG.
Yeah, EKG is very important. You have to exclude AFib. Yes, excellent. And you can put her on telemonitoring if you want to, if you have access. I know it's not available in Ethiopia, but here right away you can put them on telemonitoring and you can see if there is any arrhythmia or not continuously. Okay, or you can simply do EKG and see if there is arrhythmia or not. Go ahead.
At the same time, we can send the blood for culture.
Are you suspecting infection? We are not suspecting infection as such. Why culture? You are wasting resource.
Infective endocarditis.
ግን ለሱ ሪስክ ፋክተር የለህማ። እቺ ሴትዮ አልጠየቀኝም። አሁን ለምሳሌ አይቪ ድራግ ዩዝ አትወስድም ብያለሁ። Why should she develop infective endocarditis? አፓረንትሊ ሄልዚ ነበረች። ምንም ካርዲያክ ኢልነስ አልነበራትም። መርመርም አላገኘንም። We are not suspecting infective endocarditis. So ንገሩኝ ሌላ ሬሌቫንት ኦልተርድ ሜንታል ስታተስ አላት ብያለሁ። What do you want to check? Sometimes patients may deny consuming any drugs, but sometimes you may be surprised, right? Especially in the younger generation. So what do you want to do? Toxicology, toxic screen. So toxicology is very important. You have to rule out if she has ingested alcohol or ingested any of the recreational drugs. Okay, quiet, Leilas. Fast, guys. Huh?
Organ function test.
ብለናል። እሱ ኖርማል ነው። ሴረም ኤሌክትሮላይትስ ኢሲጂ is normal. Echo is, yeah, echo has to be done. Why do you need to do echo?
To identify wall motion abnormalities.
Yeah, wall motion abnormality, heart failure አለ የለም የሚለውን ይነግርሃል። ቫልቩላር ሊዥን መኖሩን ይነግርሃል። ፒኤፍኦ መኖሩን ይነግርሃል። ፓተንት ፎራመን ኦቫሌ ማለት ነው። 65 ስለሆነች ኤስዲ አሁን በዚህ ኤጅ ኤክስፔክት አናደርግም። ኤስዲ ቪኤስዲ could have been diagnosed earlier. So some people might have permanent patent foramen ovale, so PFO has to be checked. So echo helps you with that. And if a patient has AFib, you want to exclude the presence of, left atrial appendage thrombus መኖር አለመኖሩን or left ventricular thrombus መኖር አለመኖሩን ማረጋገጥ ትፈልጋለህ። Okay. What else? What other investigation do you want to do?
Doppler, carotid Doppler.
Yeah, carotid Doppler. Excellent. Because, we are suspecting possibility of atherosclerosis, right? So major vessels, big vessels might be involved, like, the common carotid, internal carotid can be affected. So in fact, one of the first tests you should do is Doppler ultrasound of the carotids. Excellent. What else?
Lipid panel.
Lipid panel. Yeah, already she has history of dyslipidemia. She's on statin, but you want to check. Okay.
Urine analysis.
Why urine analysis? You
UTI
can
is a
do it.
common
Yeah, UTI is a common cause for what?
complication
Oh,
of
complication of
stroke.
stroke. ገና እኮ ነው የመጣችው እህታችን. She just arrived. She just arrived. Then, in an old lady with acute confusion, you can think of doing UA. Actually, we always do UA because patients with altered mental status in the elderly, it could be simple UTI with sepsis, So you want to exclude urinary tract infection because most of the time, these old people, they may not tell you positive history of urinary tract infection. So you have to check UA. Excellent. Good. Lelas, imaging. Go ahead to imaging. What other imaging do you want to do? Excellently, you mentioned non-contrast CT. Why do you want to do non-contrast CT?
To rule out hemorrhagic stroke.
Hemorrhagic stroke, yes. Hemorrhagic stroke has to be excluded first because it's dangerous. Okay, it's very dangerous. Because if you are dealing with hemorrhagic stroke and you give alteplase or whatever, you may kill the patient, right? So you want to exclude bleeding before you blame it into ischemic stroke, Marano. So to diagnose hemorrhagic stroke, you have to do non-contrast. But contrast corner, you may not be able to differentiate a contrast agent with a bleeding. So normally acute bleeding appears wide or hyperdense on a CT scan. So you do non-contrast CT scan, and if there is no sign of acute bleeding, you do other tests. So CT, level 1 CT, we call it level 1 CT to exclude bleeding, was negative in this patient. Chest X-ray, you can do that. Yeah, you may see aspiration or you may see any lung pathology if there is any. At chest X-ray was normal. So CT was normal. Then what other modality do you do next?
MRI is better at identifying ischemic changes, so we do MRI.
Beautiful. So CT is negative means you don't stop there. Of course, CT may be able to diagnose ischemia, but sometimes it may take some time for ischemia to appear on CT scan. MRI is more sensitive, so you have to do MRI of the brain. Okay, good. Guys, don't leave, don't leave. This presentation is becoming more interesting and you are leaving. I know, we took a longer time, I guess, but be patient. I am not tired. Don't be tired, okay? Bedside beyond ጥላችሁ አትሄዱም አይደል? You stay until the bedside is over. And bedsides normally last more than 2 hours. As far as I'm concerned, they may last between 2 to 3 hours. We do extensive discussion and then, you will have a solid knowledge. That is why I don't like, superficial discussions. I want to stimulate, thoughts in depth. So please be mindful of that, okay? አይሰልቻችሁ ማለቴ ነው። አይሰልቻችሁ. Do you want to take a break a little bit or shall I continue? ቶሎ ቶሎ እንጨርስ። ትንሽ ስላይድ ነው የቀረን actually. We have discussed most of it. All right, so what else do you want to do? MRI, right? So MRI እና CT ብቻ ሌላስ? Ordinary MRI of the brain may not be enough. You have to diagnose. Like if it is like, big vessel atherosclerosis, you cannot diagnose it with simple brain MRI, Adam, or with simple CT of the brain. You cannot diagnose major vessel atherosclerotic lesions, right? So what do you want to do to exclude those lesions? Hmm? Come on, guys, wake up. Elizabeth, B, Razina, try, give it a try. Brooke Zex, the qualifier. Dasalegn, Leah. Okay, you
Can
are
you
answering.
repeat the question?
So yes, MRA, he answered it. CT angiography and MR angiography has to be completed. You know, you do ordinary CT scan, you do ordinary MRI. They are negative means it may not be satisfactory, especially if you have got, you know, a major vessel abnormality, atherosclerotic lesions, narrowing blockade of the major vessels like the coronaries, the carotids. You have to do duplex and then followed by MRI, MRA. Head and neck magnetic resonance angiography or CT angiography. That helps you to diagnose aneurysms as well. So then I will ask you further. So here is it. So chest X-ray unremarkable, CBC, BNP unremarkable, lipid panel unremarkable. The only thing elevated total cholesterol and LDL, low HDL, EKG normal, sinus rhythm, UDS was negative, D-dimer negative, troponin has to be checked. That was negative, PT, PTT-INR, everything is normal. And random blood sugar was also normal. Okay, that's very important. These are the type of tests you want to run. As far as imaging is concerned, CT head, equivocal, hypodensity. So here is the findings of our patient. So equivocal hypodensity in the left middle cerebral artery territory. Then that was followed by CT angio. Then a left middle cerebral artery occlusion was evident. And then that was followed by digital subtraction angiography, confirmed left middle cerebral artery occlusion. Okay, so I will show you the image. Okay, I will show you the image. Before these are the findings of our patient. I will explain that with the image. So these are the things you could do: EKG, telemonitoring, CT head, carotid ultrasound, CT angio, head and neck, MRI brain, MRA, head and neck, echocardiography to rule out PFO, to rule out embolus and all that. Okay, good. So imaging CT perfusion also can be done, MR angiography with diffusion, weighted imaging. This is like very sophisticated imaging. MR angiography with diffusion, weighted imaging. Why is that important? Why is it important? Why do you have to do diffusion, weighted imaging? So the answer is here for patients who may be eligible for mechanical thrombectomy. So for example, like, you know, if a patient has blockade and if there is still a perfusion, if the perfusion, the diffusion weighted imaging shows you that ischemic part of the brain is still viable, then you can go ahead and do mechanical thrombectomy. Okay, it tells you whether the part of the ischemic segment is still viable or not. That's why you have to do this diffusion weighted imaging. Okay, that's very sophisticated. I know it may not be available, but you know, theoretically it's possible. You should know that. So let me talk about types of classification of stroke. Very simple. It could be ischemic stroke. I have forgotten something here. I will add it here. So thrombosis, embolism, and global hypoperfusion, right?
Yes.
ሃይፖፐርፊዥን ዝም አትበሉኝ። ጥላችሁኝ ሄዳችሁ እኮ ነው ይመስለኝ። እና ሆዴን ባርባር ይለዋል። ጭንቅ ጭንቅ ይለኛል። አሁን እንደ ብጨነቅባችሁ እንደው ፈጣሪ ሲወደዋል ተናገሩ ማለት ነው። ትንሽ አግዙኝ። Hemorrhagic stroke could be further classified into intracerebral hemorrhage, bleeding within the brain parenchyma, and subarachnoid hemorrhage. These are the two important classes, okay? How is it relevant? I will tell you. So clinical, when you are talking about in terms of differential diagnosis, you have to ask important questions. So how do you differentiate between thrombosis and embolism? How do you differentiate between the two?
The onset of the weakness is usually maximal at onset in embolic stroke.
Excellent, 100%. So embolic stroke, the deficit is maximum at the onset, and they may get better. And in thrombosis, what happens? It's kind of staggering, right? So sometimes they may have even normal findings and they may worsen. You know, it could be intermittent in between. And also it's gradual. It's not going to be sudden, and the loss of function is not maximum at the onset. That is it. Beautiful. Global hypoperfusion is just because of hypotension and the poor perfusion to the brain. Hemorrhagic. How do you differentiate between subarachnoid hemorrhage and intracerebral hemorrhage? What are the key features?
focal neurologic deficits are usually seen in intracerebral, and headache is usually the
Beautiful. Intracerebral hemorrhage, most of the time, focal neurologic dysfunctions would be there. Subarachnoid hemorrhage, it's not really common to get focal neurologic deficits. Most of the time, what is remarkable about subarachnoid hemorrhage?
worst headache.
The worst headache ever. Cluster clap. ምንድነው? ምን headache ነው የሚባለው? Cluster clap ነው የሚባለው? Cluster clap.
Thunderclap.
Thunderclap, yeah. Thunderclap headache. And very severe, the worst kind of headache in my life. That's how they describe it. And their headache is intense at presentation, just maximum at onset. Intracerebral hemorrhage, just like thrombosis, the manifestation could be gradual. The loss of function is not going to be maximum at onset because it gradually worsens through time, maybe through hours, days, or whatever, weeks. Okay. This is how you can differentiate between the types of a stroke. That's very important. So when you ask for history, you have to take these things into consideration. Okay. So let's look into the patient's X-ray, CT scan, nothing major. There is no evidence of bleeding. So at least you know that this patient doesn't have any subarachnoid hemorrhage or intracerebral hemorrhage. So we are not dealing with hemorrhagic stroke. We have excluded hemorrhagic stroke. That means then we are dealing with ischemic stroke most probably. Then you can give what? Immediately you can give something, right? What can you give? ምን ትሰጣላችሁ? ብሊዲንግ የለም።
TPA alteplase.
ኧረ ተው እናንተ ሰዎች። አትሊስት ቲፒኤ የለም ኢትዮጵያ ያለ። ኤክሰለንት ብሩክስ ኤክስ He's studying hard for quali. Aspirin, high dose aspirin. Give 325 milligram of aspirin. And sometimes you may also give dual antiplatelets like Plavix and aspirins, but you have to give aspirin right away. You have to give atorvastatin right away. She takes only 20 milligrams, so she has to get high intensity statin. So you have to give her 80 milligram of atorvastatin right away. So one thing as part of your physical examination assessment was missed. What is that? Because now you want to administer aspirin and atorvastatin, but you have to be careful about something. What do you want to assess during your physical exam? In fact, as part of the NIH stroke scale, they have to check that. What is that? A speech therapy, if available, they would do it for you. A speech therapist would do it, or any trained nurse would do it. Or you should do it. What is that, sir, guys? ኖ ቢፒ አይደለም። አሁን ቢፒ አይደለም። ከአስፒሪን እና ቢፒ ምን አገናኘው? ለዚህ ነው ኢትስ ኦኬ። ምንድነው አሁን የሆነ ነገር እንካል ብላችሁ ልትሰጡ ነው። unless you want to give it through the rectum. What are you checking? አዎ ስዋሎዊንግ አይደል? ስዋሎዊንጋቸውን ሪስክ አላቸው የላቸውም? ጋግ ሪፍሌክሳቸውን ካን ዘይ ፕሮቴክት ዘር ኤርዌይ የሚለውን ስዋሎዊንግ ስታተሳቸውን አሰስ ማድረግ አለባችሁ። ሶ ዲስፌጂያ ስክሪኒንግ ይባላል። ሶ ዩ ሃቭ ቱ ስክሪን ፎር ዲስፌጂያ ውድ ዘይ ቢ አት ሃይ ሪስክ ፎር አስፒሬሽን። ሶ ኢፍ ዘይ አር አት ሃይ ሪስክ ፎር አስፒሬሽን ዩ ሃቭ ቱ ጊቭ ዘ አስፒሪን ስሩ ዘ ሬክተም ሰፖዚተሪ ኦኬ። አዘርዋይዝ ዩ ካን ጊቭ ዘም። አሁን እዚህ ጋር አምጥተህ አስፒሪን አታስውጥም። አስውጣለሁ ስትል አስፒሬት ቢያደርግ ዩ ዊል ኢትስ ዘ ሜዲኮ ሌጋል ኢሹ if the patient aspirates. So you have to check for dysphagia screen. Don't forget. No, it won't tell you. And they bulbar muscle involved ከሆነ Glasgow coma scale 15 ሆኖ they may still aspirate. Brooks X. It's not a guarantee. dysphagia ያላቸው የላቸውም የሚለውን ማወቅ አለብህ። cranial nerves are getting involved. ምላስህ ምን ለዛ እኮ ነው cranial nerve involved የምታደርገው። ፋሪንክስህ እኮ is supplied by the cranial nerves. So you have to check, okay? That's very important. And then you give them these medications. ከዛ በኋላ ስለሌላው ነገር እናወራለን። አሁን መጀመሪያ እኮ እርግጠኛ አይደለንም። አልቴፕሌዝ አንስት የምንለውን ነገር we have to make sure that we are not dealing with embolic stroke ከሆነ you don't have to do that.
How do we assess for then how do we assess for dysphagia?
I think dysphagia they give them something መሰለኝ. I don't know, there is a mechanism. I will find out. The nurses usually do it and they tell me like a patient has passed dysphagia screen and we go ahead and do it. I think ትንሽ የሆነች ነገር ይሰጧቸዋል ይመስለኛል and they will assess. whether they will swallow it perfectly ይውጣል አይወጥም የሚለውን ያወጣል። I have never done it. I will ask.
Thank you.
Very important. It seems silly, again. I don't know. I have never done it because they do it for me. Then nice question. I'll find out. Okay, I'll find out. So the nurses do that screening for you, and they will tell you. They will tell you even diet ራሱ request አናረግም. Doctor patient has passed has cleared the dysphagia screen እና ዳይት እንስጠው ወይ ዳይት ኦርደር እናስገባው ብለው ሁሌ ይጠይቋቸዋል። ምክንያቱም automatically you keep the patient NPO until the patient passes the dysphagia screen. ግልጽ ነው? የፕራክቲስ ጋፑንም በዛው እያስተዋላችሁት ነው አይደለ? There is a big practice gap. We are managing patients here and there. It's small things ናቸው doable እኮ ናቸው ግን we don't practice it systematically. So our lady you see እዚህ ጋር middle cerebral artery blocked ሆኗል እዚህ ጋር you can see the artery is cut off here. Then they did angiography. Then you can see the middle cerebral artery is already blocked here. It's blocked. ምንም አይነት circulation የለም በራይት ሳይድ እንደምታዩት it's blocked. So then what shall we do? So አሁን finding one አይታችኋል. So what is the differential diagnosis now? So you saw everything, right? So ሁሉን ነገር ተነጋግረናል። ሶስት differential diagnosis አለን። ስትሮክም ምንም ብለናል። ቲአይም ብለናል። ምንድነው ሰብዱራል ሄማቶማም ብለናል። ስለዚህ አሁን ዲፈረንሻላችን ምን ሆነ?
ischemic stroke.
ምን ሆነ?
Ischemic stroke.
Ischemic stroke. That is because of blockade of the middle cerebral artery. Subdural hematoma is out. TI is out. Already ischemia እንዳለ diagnose አድርገናል. So it's not TI, it is full blown stroke. She has ischemia. So ischemic versus hemorrhagic, it's no more hemorrhagic. Hemorrhagic stroke is out. She has ischemic stroke. So ischemic stroke further can be classified into embolic ነው ብለናል፣ thrombotic ነው ብለናል። እና ኢምቦሊክ ከሆነ ሶርስ ኦፍ ኢምቦላ ከየት ነው? እስቲ ቴል ሚ።
Cardioembolic is from the heart.
እሺ ሌላስ?
Artery to artery.
Excellent. Artery to artery. So which artery is famous for that?
Carotid.
Before the carotid you have another major artery. The carotid is a branch of what?
Aortic.
Aorta, yeah, aorta. If there are atherosclerotic lesions in the aorta, some of them they crack and then some particles may go to the brain. So yes, it could be the source could be the aorta, it could be the carotids. Okay, one of the major vessels. The vertebral arteries could also be the source. Okay, vertebral arteries, the carotid arteries, especially the internal carotid artery, main carotid artery, aorta, they are potential sources. Okay, for embolism. Or you can have atherosclerotic lesions involving these major vessels like the internal carotid or the middle cerebral artery. So then just like MI, when there is a crack in the thrombus in atherosclerotic lesion, there is a chance that there is, platelets, they come and aggregate, a clot forms, and that further narrows the lumen of the blood vessel and acutely it cuts the blood supply to that area which is supplied by that territory. By that vesel's territory. That's the mechanism. The atherosclerotic lesion will have a crack. In that crack, that's a NIHSS for clot formation. Clot forms there. That clot acutely blocks the artery and cuts off the arterial blood supply. So now we are dealing with ischemic stroke. This is how we narrow differential diagnosis. This is how we implement our thinking and implement relevant imaging. And then you reach at a specific diagnosis, then the action would be dependent on what you find. So anything to do to this patient? What interventions do you want to do to this patient? So we gave aspirin, we gave atorvastatin. What else do you want to do? She presented early. She presented after 1 hour of the onset of her illness. So is she a candidate to TPA?
Yes.
Yeah, so what is the cutoff point? What is the cutoff point? So do you give TPA if a patient comes after 5 hours? አረጋ ጋይስ አንብቡ እንጂ እዚህ ያለ እኮ መልሱ ይኸው
No,
እዚህ።
4 hours.
Yeah, it has to be less than 4.5 hours or 4 hours. So if the presentation is, that is very important. So if you are suspecting a stroke, always ask, when was the last well time known? Okay? መጨረሻ ጊዜ ደህና የነበርከው ጤነኛ የነበርከው ዊክነስ ያልነበረሽ መቼ ነው ብላችሁ ሰዓቱን ካልኩሌት ማድረግ አለባችሁ። If a patient is out of this window, you don't give TPA. It doesn't help. Alteplase doesn't help. So that's very important. Always ask for this information. It's very important, especially if you are working in a center where you can offer TPA, so aspirin can be given, atorvastatin, allow permissive. Do you want to control blood pressure? 190 በ120 ነው ምናምን ነበር አይደል blood pressure? Do you want to lower it down or keep it high for some time?
We have to keep it high to prevent. We have to keep it high.
Yeah, so ምንም አናረግም ማለት ነው. Unless the blood pressure goes up, systolic greater than 220, diastolic more than 120 በላይ ካልሄደ በስተቀር we don't take any action. Okay? So if it is more than 220 systolic, more than 120 diastolic, then you have to intervene. You have to give labetalol, hydralazine, and all that, IV. You know, these are reversible እና reversible ስለሆኑ long term ስለማይቆዩ you can give these medications. Nicardipine and all that can be given. Nicardipine or labetalol, hydralazine can be given. They are short acting, easily reversible ስለሆኑ ቶሎ ኢፌክታቸው ስለሚያልቅ you can try to lower it only if it is wild above 20 and 120 diastolic. Otherwise, don't do anything. We call it permissive hypertension, and most neurologists recommend permissive hypertension for about 48 hours, okay? Following the onset of the symptoms, ischemic stroke. The management of hypertension in hemorrhagic stroke is completely different. Why is that?
In hemorrhagic stroke, we have to keep it lower to prevent further bleeding.
Thank you so much. So that is one of the reasons why you have to do imaging right away. So are you dealing with hemorrhagic stroke or ischemic stroke? Still ischemic stroke, don't worry about blood pressure unless it is very high. But if it is hemorrhagic stroke, yes, worry about worry about blood pressure, manage it effectively. Okay, because otherwise more bleeding will happen and patient's course would complicate. And the other thing is, if you are going to do TPA, then the only reason to manage blood pressure in a patient with ischemic stroke would be if a patient is a candidate for TPA. So what is the cutoff point? How low should be, how much should be the cutoff point for blood pressure? Otherwise, contraindication ይሆናል beyond certain number ከሆነ. What is that number?
120
Huh?
systolic. 120 systolic.
What
And
about
diastolic 100.
አይ አይደለም፣ ሌላ መልስ ሞክሩ። ሲስቶሊክ ከስንት በላይ መሆን የለበትም?
185.
Excellent. And what about the diastolic? 140 አይደለም፣ 140 አይደለም። ኢቨን እኮ ቅድም እኮ ኢቨን ከሞር ዛን 120 ከሆነ diastolic እኮ ማኔጅ it ብያለሁ። even without TPA. So I think it is less than 100 መሰለኝ መሆን ያለበት። 185 over 100 መሆን አለበት። Check it, okay? Double check it. I'll check myself as well, but I think it is 185 over 100, I guess. You can Google for indications for TPA and blood pressure for TPA. All right, and then you have to always consider the presence or absence of contraindications for TPA. Okay, ዝም ብላችሁ ሮጣችሁ አትሰጡም። ለምሳሌ አሁን past surgical history relevant ነው ያልነው. One of the reasons why recent surgical history is relevant is for this reason. If a patient has major surgery in the past three weeks, you don't give TPA. If the patient had major neurologic surgeries or spinal surgeries in the past 3 weeks, you don't give TPA because they will bleed. Okay, you give them another trouble on top of what they have. So always there are indications and contraindications. I didn't bring the list. The list is long. This is going to be your assignment. Okay, indications and contraindications for TPA. Okay. Then once you do stabilizing effects, you have to transfer the patient to a comprehensive stroke center if available. You know, not all centers, even in the US, are stroke centers. There are institutions who are designated stroke centers. Okay, they have to be designated. የአሜሪካ መንግስት የራሱ criteria አለው. You have to qualify for that. If you are not a designated trauma stroke center ካልሆናችሁ, you have to refer them to those centers and transfer to comprehensive stroke center if available. Okay? Brooke Zex, you can go ahead. I see that you are raising your hand በአክሲደንት ካልሆነ.
አይ በአክሲደንት አይደለም። አቶ ቫሳሲኑ if her lipid panel was normal,
yes,
would we still have to increase it to this degree?
Yeah, you increase it. Yeah, most of the time, you know, you have to give atorvastatin, high intensity statin ላይ ነው መሆን ያለባቸው. You have to be very aggressive ማለት ነው in preventing further worsening of vascular lesions, atherosclerotic lesions. So you manage it aggressively. And that is part of secondary stroke prevention as well. Already ያለው damage, of course, the damage is done, but basically you are focusing on secondary stroke prevention. And the patient has to be on high intensity እንትን ላይ መሆን አለባቸው ስታቲን ላይ ብሩክ የተመለሰ ያጨበጭብ
ተመለሰ
okay further care she underwent mechanical thrombectomy so she underwent mechanical thrombectomy with recanalization of the middle cerebral artery. I will show you the picture. Then the next day they calculated the NIHSS score and it dropped from 22 or 20 to 2. You know, she remarkably improved. And 3 months later, she had no neurological deficits. So time matter ያደርጋል የሚባለው ለዛ ነው. Time really matters in stroke management. Time matters. ወዲያውኑ በቃ በጣም you have to really advocate these patients ቶሎ እንዲመጡላችሁ በጣም advocate ማድረግ አለባችሁ. I think there was one slide. I think there is. I will bring it. So ወደ dedicated stroke center መላኩ የጠቀመው, you know, the interventional radiologist or the interventional neurologist can do mechanical thrombectomy. That's what they did, you know, endovascular intervention is possible other than the TPA. Okay. And then this is the outcome. Now you can see that part of the middle cerebral territory is back on. And after 3 months, she doesn't have any neurologic deficits whatsoever. And in summary, let's do that. So stroke care, it doesn't stop there. I will talk about it in the next few slides. So they have to start working with physical therapist, occupational therapist, and the speech therapist as much as possible. So then, you know, they will regain their motor function, sensory function, and also their memory as well as speech recovery. Okay, so stroke care is a team approach. It has to be comprehensive. DVT prophylaxis, excellent. DVT prophylaxis is also very important because this lady is going to be, you know, bedridden for a couple of days and she's prone to develop DVT. So DVT prophylaxis is also very important. Okay, low dose heparin can be implemented. So let's summarize things. B fast. So you have to remember this acronym. B is loss of balance. E is eye problems. F is face, you know, facial palsy. A is arm. Your arm is weak. And the S is speech, dysarthria and all that. T is time. Time is important. So immediately call 911. Okay. So be fast. This is a basic principle, and everybody has to know. In our hospital, in every corner, in the elevator, this is posted everywhere in the wall so that people will be aware. So when they see one of these symptoms, they have to call 911. They don't even have to drive themselves to the emergency department because their lesion can progress and they could be in trouble. And they will be in trouble. They would put the society in trouble. Okay, let's summarize clinical course of symptoms. You know, read these things. We talked about it. You answered it already. You know it already. I just brought it here because you guys need some sort of reference so you can read about how to differentiate between ischemic stroke versus hemorrhagic stroke. How do you differentiate between ischemic thrombosis versus embolic and all that? Okay, so it talks about all those things. And neurologic examination for localization, you can read these things. I'm giving you a couple of examples, a couple of neurologic findings which help you to localize where exactly the lesion is and all that. So in our patient, since she has global aphasia, then you know that both the temporal lobe, the frontal lobe is affected, the motor cortex is affected because she has weakness and all that. Can you mute whoever is trying to give me hard time? Abnormalities of language, vertigo. So if you have vertigo, staggering, diplopia, deafness, crossed symptoms, this tells you that the posterior circulation is affected. Okay, so whereas abnormalities of language might tell you anterior circulation, like middle cerebral artery is affected. Okay, basilar artery, vertebral artery is affected. Posterior circulation is affected. Your finding would be vertigo, staggering, diplopia, deafness, cross symptoms, and coordination, loss of coordination and everything. So we forgot to mention about coordination as part of our physical examination. So you have to check coordination, okay? The shin to knee, the hand to nose kind of coordination examination should be done. And acute stroke differential diagnosis, especially if a patient comes with altered mental status, all this can be differential. You mentioned migraine, you mentioned seizure, you mentioned infections, tumors, cerebral venous thrombosis, functional deficits, hypertensive encephalopathy, head trauma, mitochondrial disorders, okay, multiple sclerosis, press syndrome, spinal cord disorder, subdural hematoma, syncope, systemic infections, toxic metabolic disturbance like hypoglycemia, drug intoxication, transient global amnesia, viral encephalitis, Wernicke encephalopathy. All these are potential differential diagnoses. So the list is too long. So if I said altered mental status, weakness of right-sided extremity weakness, basically, and if I tell you like, 1 week or 5 days, then, the list of your differential could have been as long as this one. Okay. So your differential diagnosis really depends on the chief complaint, and the list could be as long as this one. And you should be able to narrow. And how do you narrow it? We already did it. We practiced it. So finally, general management principles, IV thrombolysis and endovascular thrombectomy for ischemic stroke, antithrombotic therapy with aspirin as soon as possible after stroke onset. So most people, you can advise people, if they are suspecting a stroke, tell them to take 325 milligram aspirin. The society should know about this. So if they have facial palsy, if they think they have weakness and they're suspecting a stroke, they can take high dose aspirin before even coming to the hospital. That prevents further clot formation and they save themselves. Okay. So educate the society. That's why I'm on TikTok. I'm justifying why I'm active on social media. So prophylaxis of deep venous thrombosis, pulmonary embolism, antithrombotic therapy at discharge, like, aspirin, sometimes dual antiplatelet therapy can be given to patients like Plavix and aspirin, okay? Lipid lowering agents, blood pressure reduction. So after the acute period has passed, obviously you have to properly manage the blood pressure because the blood pressure is the main culprit why patients are developing arteriosclerosis to begin with. Behavioral and lifestyle changes like smoking cessation, exercise, weight reduction, obesity management, Mediterranean style diet, and also sometimes counseling and psychiatric evaluation if they are depressed is very important because, somebody who is active becomes completely dependent on others. That is depressive. Patients may have significant depression, psychological crisis. So you should really counsel them as well. Okay, that's very important. And if it is hemorrhagic stroke, we didn't talk about hemorrhagic stroke. If it is subdural hematoma, most of the time the commonest cause is, very aneurysm rupture. So coiling can be done or clipping can be done, depending on the access. So in most centers in the US, they can do endovascular intervention with coiling of the aneurysm, and that's it. Or the neurosurgeon can do clipping of the aneurysm. That's it. You fix it that way, subarachnoid hemorrhage. If it is intracerebral hemorrhage associated with mass lesion, increased intracranial pressure, at least sometimes patient is comatose, increased ICP, deteriorating, then the only way you can prevent this is by alleviating the intracranial pressure. For that, you have to remove part of the calvarium. We call it craniotomy. So you leave the brain, the calvarium open for a couple of days until the edema subsides. Okay, sometimes some surgeons might try to drain intracerebral hemorrhage, and that's associated with increased morbidity and mortality. Okay. If it is subdural hematoma, epidural hematoma, they are not part of a stroke, but they are extraaxial. They may present with this kind of presentation. You have to drain both subdural hematoma. If it is chronic subdural hematoma, you drain it by doing simple burr hole. If it is acute subdural hematoma, you have to do craniotomy. If it is acute epidural hematoma, most of the time epidural hematoma is acute related to trauma. You have to evacuate it by doing craniotomy, not burr hole, because it's clotted. You need to remove big part of the calvarium so that you can evacuate the clotted blood. That is the same is true with acute subdural hematoma. Okay. Chronic subdural hematoma, you can simply make a hole in the calvarium, a hole in the dura. It's under pressure, it comes by itself. It's already hemolyzed the blood. You don't have to have a big hole to evacuate it. Okay. Ashoyna no? Guys. Are you happy? Are you satisfied? Is it good?
Yes.
Okay.
Yes.
Good. Do you want to try one or two questions?
Yes, sure.
Beautiful. Thank you so much, guys, for coming. Okay.
Thank
You
you.
are the best. You are the best. You are my favorites. Because you volunteered to hear my crap. Right? So I give you big credit for that. Yeah. Let's do a couple of questions. Do you see the question?
Yes.
Okay, አንብቡና መልሱ። አንድ ሰው ጮክ ብሎ ያንብብልን ለግሩፑ።
49-year-old woman is evaluated in the emergency department for sudden onset severe headache of 24 hours. Duration. The headache reached its peak intensity within 1 minute. She is otherwise well and takes no medications. On physical examination.
Stop there. What is your differential diagnosis, Beza?
Subarachnoid hemorrhage.
Excellent. You are my favorite, by the way. አንደኛ you are participating, you are active። እንደዚህ አይነት ተማሪ በቃ ማይ በዲ ነው የሚሆነው። ጠይቁ ጥቁር አንበሳ ሄዱና ጎበዝ ልጅ ቀጥይ።
On physical examination, vital signs are normal. Neutral rigidity is present. Findings on mental status and fundoscopic examinations are normal. There is no cranial nerve deficit. CT scan of the head is normal. Which one of the following is the most appropriate next step in management? A. Cerebral catheter angiography. B. Lumbar puncture. C. Magnetic resonance venography of the brain. D. Oral sumatriptan.
What shall we do?
Lumbar puncture.
Excellent. Let's see. እንማ ለሌላ ተማሪ እድሉን አልሰጥብሽም እንደዚህ ደክመሽ። Yes, you got it. Lumbar puncture. Because, CT is negative doesn't exclude the fact that the patient might have subarachnoid hemorrhage. ምክንያቱም if the amount of bleeding is not significant, sometimes, ለትንሽ second እኮ ነው የሚደማው። Barrier aneurysm bleeds for a very short few seconds and then it stops. Rebleeding is common. They can bleed time and again. Repeatedly ሊደሙ ይችላሉ ግን it's a very brief bleeding. ስለዚህ ፒክ ላይ ይደረግ ይችላል with the CT scan. So ካራክተሪስቲክ ነው። ለዛ ነው ያስቆምኩሽ። ዲፈረንሻል ዳያግኖሲሱ ገና ከላይ ፈርስት ላይኑ ስታነቢው ሰባራኪኖይድ ሄሞሬጅ እንደሆነ ግልጽ ነው። Thunderclap headache is a severe headache that reaches maximum intensity within 1 minute and is medical emergency. That warrants immediate evaluation with a head CT scan, which is non-contrast. Patients with suspected subarachnoid hemorrhage but a normal head CT scan require a lumbar puncture. lumbar puncture ላይ ምንድን ነው የምናገኘው?
RBCs.
What do you call it?
The color of the CSF.
ምን ይባላል? What do you call it? There is a terminology for that. CSF ምን ይባላል? CSF xanthochromia, right?
Yes.
ያ ላይክ እንደዚህ ቀይ ነገር ብርቱካናማ ነገር ይሆናል። ደፍረስ ያለ ማለት ነው። ከለርለስ ነው ሲኤስኤፍ ኖርማሊ እና ቲፒካል ዛንቶክሮሚያ ካለ ብለድ አለ ማለት ነው። አናላይዝም ስታደርጉ ዩል ሲ ብለድ ፕሬዘንት ኢንዲ ሲኤስኤፍ ኖርማሊ ፕሬዘንት መሆን የለበትም። ይሄን ማን ቮለንቲር ያደርጋል? ሌላ ልጅ እንደ ቤዛ የኔ ፋቨራይት መሆን የሚፈልግ እንዴ? ሊሮይ የት ገባ? ደክሞ የት ሄደ? ሊሮይ ዲድ ዩ ሌፍት ሚስተር ሆስት? ይሄ ሾላ አካሄዷል። እሺ ገመቹ ያፌት
So, a 67-year-old.
አንብበ ያፌት ቀጥል።
Okay. A 67-year-old man evaluated for a 1-minute episode of right-sided weakness and aphasia that occurred yesterday. The patient also has type 2 diabetes mellitus treated with metformin. On physical examination, blood pressure is 164 by 100. All other vital signs are within normal limits. Cardiac examination reveals a regular rhythm, no murmur or carotid bruise are heard on cardiac auscultation. A neurologic examination has normal findings. Which of the following is the most appropriate next diagnostic test?
አንብባቸውና መልስ። አንዱ ሞክር፣ አይዞህ። ብትሳሳትም ችግር የለውም። ደግሞ አትሳሳትም።
C.
Magnetic resonance angiography of the brain.
Yeah.
Let's see. Carotid ultrasonography. Do you remember what I said when we talked about investigations? So the first imaging modality you should do is carotid duplex ultrasound. Then, if that is negative, then more sensitive የሆኑና ወደ ውስጥ ያሉትንም ደግሞ ዳያግኖስ ሊያደርጉልህ የሚችሉትን ኤምአርኤ፣ ሲቲ አንጂዮ ምናምን ማዘዝ ትችላለህ because they are more sensitive than the carotid ultrasound. Okay, but initially you can do carotid ultrasound. So let's read the explanation. The risk of stroke after TIA is highest in patients with extracranial internal carotid artery stenosis. Okay, so carotid ultrasonography should be performed emergently in patients with transient ischemic attack to identify those who may benefit from surgery. Okay, so that's what you should do it. ለምንድን ነው ሲ ያልሆነው? ሲ ያልሆነበትን እንየው። So magnetic resonance angiography is an extensive test and may not immediately change management. Intracranial atherosclerosis is associated with high risk of stroke after TIA and minor stroke. And the indicated treatment for stroke prevention is best medical therapy. So intracranial stenting is high risk without significant reduction in stroke. So MRI of the brain also will not result in an immediate change in management and is high cost. Cost high now, more complicated now. Management as such አይቀይርም። ገባ? እና you can get the information with ultrasonography. And the latest American Heart Association guidelines do not recommend routine use of MRI in the patient in the inpatient setting. An infarct present on MRI will not change recommendations on initiation of antithrombotic treatment or necessarily inform risk of stroke better than the less extensive carotid imaging. After the initial diagnostic testing, an MRI may allow for further stroke subtype and confirm the diagnosis of minor stroke. ስለዚህ the first test you should do is carotid duplex, and depending on the findings, you can advance it. ግልጽ ነው? It's more available, it's safe, it's cost effective, it's available in most centers, so you should do that. Let's do one more question and then we can call it a day. ሎንግ ነው ይሄ ጥያቄ። አጠር ቢል ጥሩ ነው። ጸልዩ አጠር ያለ እንደው ይሄው አንድ ሰው ቮለንቲር
A 34-year-old woman is hospitalized for right-sided visual loss of 2 days duration. She has no headache, eye pain, or neck pain. She has had 2 prior pregnancies without complication. She has no other symptoms and is otherwise well. On physical examination, vital signs are normal. Right visual field deficit in both eyes is observed. Pupils are equal in size. and are reactive to light. She has full eye movements. Complete blood count, coagulation profile, and C-reactive protein levels are normal. CT scan of the head shows left occipital infarct. Magnetic resonance angiogram of the head and neck and ECG are normal.
ቀጥል። አንብበዋ ቀጥል። አይዞህ አትፍራ።
Okay. Which of the following is the most appropriate diagnostic test to perform next? Catheter angiography, lumbar puncture, transesophageal echo, transthoracic echo with agitated saline.
ስለዚህ
Catheter angiography.
boom. Transthoracic echo with agitated saline. Okay. Reason on a need. The leading cause of a stroke in a young patient with no risk factors includes cervicocephalic artery dissection. Yeah, ሌላኛው ይሄ ነው by the way. One of the reasons for ischemic stroke atherosclerosis ብቻ አይደለም። arterial dissection አለ። ሌላ ደግሞ ምን አለ? Fibromuscular dysplasia. That means the muscle wall of the blood vessel is affected. Fibromuscular dysplasia of the basal wall is another risk for ischemic stroke. The other one is dissection, okay? And the other one is, of course, atherosclerotic lesions. Leading cause of stroke in a young patient with no risk factor includes cervicocephalic artery dissection, hypercoagulable state, vasculitis, and embolism via patent foramen ovale. Transthoracic echo with agitated saline injection is indicated in younger patients with a stroke without other risk factors. Do you get it? It's because of the age, you see? She's 34 and there is no risk factor for a stroke. Hypertensive diabetes ምን የምትለው high cholesterol ምን የላትም። So atherosclerotic lesion ካልሆነ either arterial dissection ነው ወይ embolic stroke ነው ማለት ነው. So to find out አንዱ common source of embolism is the heart. So you have to do atrial fibrillation ምን የላትም ደግሞ EKG-ዋ ምኗ ኖርማል ስለሆነ arrhythmia አይደለም. So that means maybe like she may have patent foramen ovale and that may be the reason why she is getting this one. So you have to do transthoracic echo. ግልጽ ነው? Yeah, transesophageal echo right and left indicated አይደለም. You can do it rarely. So one last question about management ከዛ we will finish, okay? Let's do one treatment. Treatment related. This question has been updated. Okay. ይችን መልስ ውስጥ ቆይ አፕዴትድ ከሆነ አፕዴትድ የሆነ ጥያቄ መጠየቅ የለብኝም። ይችን መልሱ። ከዛ ላስት question, okay? አንድ ሰው አንብብ እስቲ። ሴቶች እህቶቻችን የጾታ ተዋጽኦ ረዚና ሴት ነሽ? ኤልዛቤት አለሽ? ሊያ አለች? እስቲ እህቶቻችን ድምጻችሁን እንስማው። መጨረሻ ላይ ደግሞ ከየት ሜዲካል ስኩል እንደመጣችሁ ቴክስቱ ላይ ታውልን in the meantime። እሺ we want to know የት መስራት እንዳለብን ማወቅ አለብን በማስተባበር ላይ ዙሪያ ማለት ነው። አሁን የጠራዋችሁ እህቶቻችን እባካችሁ አንዳችሁ ኦነር አርጉን by speaking up. ቅዱሳን
A 72-year-old woman is evaluated in the emergency department for 1 hour history of left-sided weakness. The patient has hypertension and dyslipidemia. She has had no recent surgery or history of gastrointestinal, genitourinary, or intracranial bleeding. Medications are amlodipine and atorvastatin.
ለምን እያዘጋጀሽ ይመስልሻል? ማነሽ የምታወሪው? ያብስራ አሁን ጥያቄው ለምን እያዘጋጀሽ ይመስልሻል? ትንሽ ኢንታልስ አላገኘሽም? እስካሁን ካነበብሽው ኢንፎርሜሽን
ለስትሮክ because she has hypertension
ስትሮክ ፕላስ ትሪትመንት ነው ብለናልና ለሆነ ትሪትመንት እያዘጋጀሽ አይመስልም? ለምን ይመስልሻል? ዝም ብለሽ ስትገምጪ እየነጋገረች ነው። ጂአይ ብሊዲንግ፣ ጄኒቶዩሪነሪ ኢንትራክራኒያል ብሊዲንግ የላትም፣ ሪሰንት ሰርጀሪ የላትም ምናምን እያለች ነው። ምን ሊጠይቅሽ ይመስልሻል?
አንታይኮአጉሌሽን ሜዲኬሽንስ
አሞስ ፕሮባብሊ የሆነ ነገር ሊሰጣት እያሰበ እንደሆነ ትገምቻለች። ቴስት ቴኪንግ ካፓሲቲያችሁንም አሳድጉት። ቀጥይ። በቃ ዚስ ኢዝ ሃው ዩ አናላይዝ ኮስችንስ ኤንድ አናላይዝ ኬዝ። ቀጥይ እህቴ። ኦን ፊዚካል ኤግዛም ብለሽ ቀጥይ።
On physical examination, blood pressure is 168 by 92. The remaining vital signs are normal. Oxygen saturation is 97% with the patient breathing ambient air. Left facial weakness, dysarthria, decreased sensation to pinprick on the left side of the body, and left arm and left drift are noted. A bedside swallow examination is positive for dysphagia. Her score on National Institute of Health stroke scale is 6. Neurologic examination reveals a normal mental status. The remainder of the physical examination is normal. A CT scan of the head without contrast shows intracerebral hemorrhage, no intracerebral hemorrhage or early hypodensities. Which of the following is the most appropriate treatment? A. Intravenous alteplase. B. Intravenous low molecular weight heparin. C. Intravenous nicardipine. D. Oral aspirin. So she has dysphagia, so oral aspirin is not an option.
ቀደምም ሂንት ሰጥቼሻለሁ። 1 hour ነው አለሽ፣ ብሊዲንግ የለም አለሽ፣ ሰርጀሪ የላትም አለሽ፣ ብለድ ፕሬሸሯ 168 በ92 ነው አለሽ፣ የመጣችው ዊዝን 1 hour ነው አለሽ። ይሄ ሁሉ ሂንት ሰጥቶሻል። እኔም ለኤምፋሳይዝ እንድታረጊው ጠቆም አድርጌሻለሁ። ለሆነ ሜጀር ትሪትመንት
TPA. So we give her IV alteplase.
ልንካው?
Yes.
ንካው በይ።
ንካው.
You got it. Very easy. Even the question, if you really understand the subject matter, the way the case is constructed is dictating you. So they are just excluding the contraindications. They are telling you the contraindications are absent. And they are telling you she fulfills the criteria. So less than 1 hour, blood pressure within normal limit. Normal, elevated, but less than 185, less than 100 diastolic. So she fulfills the criteria for TPA, and she doesn't have the contraindications for TPA. She looks like our patient, አይደል? የኛን patient አትመስልም? እድሜዋን ምኗን 60-72 መሆኗ ነው እንጂ እና ይሄ ሌፍት ዊክነስ መሆኗ ነው እንጂ ሺ ኬም ዊዝ 1 hour ምናምን በቃ የኛን ነው የምትመስለው። የኛን ዲስከስ ያደረግናትን ፔሸንት። ሶ ሺ ኢዝ አ ካንዲዴት ፎር ቲፒኤ። ግልጽ ነው። አሁን በቃ ኢትስ ታይም ፎር ፊድባክ። ይበቃችኋል። ብዙ እውቀት ጨብጣችኋል ብዬ ተስፋ አደርጋለሁኝ። ኢንላርጅ ላርገውና መጀመሪያ የት ትምህርት ቤት እንደሆናችሁ ንገሩኝ። ቢካዝ አይ ዋንት ቱ ኖ ከየት ስኩል እንደምትመጡ። ከዛ በተጨማሪ ደግሞ ለሚነው ያላችሁን እንትን ንገሩንና እንጨርሳለን። ከየት ሜዲካል ስኩል እንደመጣችሁ ንገሩን። ወይ በቴክስት ንገሩን ወይ በቃል ንገሩን። መናገር የምትፈልጉ ልጆች ንገሩን በቃል። how do you make it big ብሩኬ? እዚህ አንድ ረዳት ያስፈልገኛል። እንዴት አድርጌ ላምጣችሁ እዚህ?
ምኑን ነው?
I am trying to make it big, full screen እንዲሆን ይሄ እንትኑ።
አይ ስክሪን ሼሩን መጀመሪያ ብታጠፋው ስክሪን ሼሩን መጀመሪያ ብታጠፋው
ያኔ ይፈወሳል። ኦኬ። አይ ተማሪ ግደለኝ። ለርንድ ፕሊስ ኪል ሚ የሚባለው እኮ ለዚህ እኮ ነው። ከየት ሜዲካል ስኩል ናችሁ? እስቲ ንገሩኝ ወንድሞቻችን እህቶቻችን።
ያፊት from Langston Medical College።
እሺ ስማችሁን እጠራለሁኝ። ብሩክ ዜክስ፣ ብላክ ላይን፣ ጆቼ ቤድ። ማነው ስምህ ወይም ማነው ስምሽ? and from which medical school?
ጆካቤድ ይባላል ከኮሪያ ሆስፒታል።
ምን ማለት ነው ጆካቤድ እህቴ?
እግዚአብሔር ክብር ነው።
አሜን አሜን አሜን። በእንትን መሆን አለበት፣ በዕብራይስጥ ምናምን መሆን አለበት። ኦኬ በጣም ቆንጆ ስም ነው። እሺ ስለመጣሽ ደስ ብሎናል። ያፌት አበበ
ከማንግሰን ሜዲካል ኮሌጅ ወይም ኮሪያ ሆስፒታል።
ኮሪያ ሆስፒታል 2 ኮሪያ 2 ለ1። ናኦል ዲሳሳ
ከብላክ ላይን
ብላክ ላይን ሁለት እኩል። እሺ ዌልካም ናኦል። ቢኒያም ቢኒያም ቢኒ እሺ
ብላክ ላይን
ቤዛ
ብሏል።
የት ነው አለ?
ብላክ ላይን ብሏል ኢን ዘ ቻት።
ብላክ ላይን እሺ። ቤዛ እስራኤል
ኮሪያ
ኮሪያ ሆስፒታል ዌልካም አወር ሲስተር። ሊያ ተሾመ
ብላክ ላይን
ብላክ ላይን ሶስት እኩል። በአምላክ
ኮሪያ ሆስፒታል
ኮሪያ 4-3። የአብስራ
ኮሪያ
5-3። ኤልዛቤት
ብላክ ላይን
5-4። ረዚና ረዚና አለች
ብላክ ላይን ብላለች።
ብላክ ላይን 5 እኩል። አቤኔዘር
ኮሪያ
ኮሪያ 6-5። ቢ ታይ ብሬከር
ዊ ሉዝ ብላክ ላይን
ብላክ ላይን 6 እኩል ማለት ነው። ጥሩ ስለመጣችሁ በመጀመሪያ በእውነት ሁላችሁንም አፕሪሼት አደርጋችኋለሁ። ቴንክ ዩ ሶ ማች። እንግዲህ ዚስ ኢዝ ሃው ዩ ግሮ ዩር ስኪል ኢን ሜዲሲን። አይ ኖ የመኝታ ሰዓት ሊሆን ይችላል፣ የእረፍት ሰዓት ሊሆን ይችላል፣ ወደ ቤተሰቦቻችሁ መሄድ የምትፈልጉበት ሰዓት ሊሆን ይችላል። ደግሞ ሪመምበር ለእኔም ይሄ ቫሉዌብል ሰዓቴ ነው። በጣም ረጅም ዊክ ነው የሰራሁት። አፍተር ሎንግ ዊክ ስኬጁል ምንድን ነው ስላይድ ማዘጋጀት አለ፣ ማንበብ አለ። ለእናንተ በሚሆን መልኩ ሁሉን ነገር ቆንጆ እንዲሆንላችሁ ብዙ ደክምበታለሁ ይህን ፕሬዘንቴሽን። ስለዚህ ሞር ፒፕል ኢንጌጅ ቢያደርጉ ሞር ቢጠቀሙበት። ላስት ታይም ተርናውቱ ጥሩ ነበረ፣ ከተለያየም ዳይቨርሲቲም ነበር። አሁን ያየሁት ኮሪያ ሆስፒታል እና ጥቁር አንበሳ ብቻ መሆናቸው ሜቢ ፒአራችን እንደደከመ ነው። ብሩክ ዜክስ ዛቲ ዘ ፊድባክ አጌት። ለምሳሌ ከዚህ በፊት ከሚሊኒየም ብዙ ልጆች ይመጡ ነበር፣ የሉም። ገመቹ ከየት ነው? ባይዘ ሚሊኒየም ነበረ ብላክ ላይን ነው?
ብላክ ላይን
ኮሪያ
ኤምኤምሲ ኮሪያ።
ኦኬ ገመቹ የለም፣ አሁን አላየውም፣ ወጥቷል። ማን ነው እንትናስ መጀመሪያ ገብቶ የነበረ ወንድማችን ማን ነው ስሙ? ብሩኬ
ሌሮይ is also from Korea
ኮሪያ። ኦኬ ልሩሮይ ቀድሞም መጥቷል። በጣምም ሄልፕ አድርጎኛል። ሁላችሁንም በጣም አመሰግናለሁ። ትልቁ ነገር ቢ ፓርት ኦፍ ዚስ ፕሮጀክት ጋይስ። ኦኬ ኦን አድርጉትና እኔ እንድመጣ ጎትጉቱኝ። እኔ ጎትጉቻችሁ አይደለም እናንተ መምጣት ያለባችሁ። እኔን ስሰንፍ እንኳን አበርቱኝ ማለት ነው። ስዳከም ኖ የግድህን መስጠት አለብህ በሉ። ድሮ እንደዛ ነበርኩ ነው ያዘ ስቱደንት። ለዛ ነው አሁን ማስተማር ምን ፓሽኑ ያለኝ ሞር ሄልፕ ማድረግ የምፈልገው ለዛ ነው። ድሮ እየጎተጎትን ነበረ፣ በቃ ከተቀመጡበት ሻይ ቤት እየጎተትን ነበር እዛ የጥቁር አንበሳ የተፈሩ ሲኒየሮች እንዲያስተምሩን የምናደርጋቸው። ስለዚህ እናንተም እንደዛ አይነት አቲቲዩድ ቢኖራችሁ በጣም ደስ ይለኛል። እኔ ብዳከም እንኳን እንዳልዳከም ኢነርጂ ሁኑኝ ልላችሁ ነው። ጓደኞቻችሁን ጥሩ ሰብስቡ። ሌላ ሜዲካል ስኩል ያሉትን ስሩአውት ኢትዮጵያ ያሉትን አይኖ ጎንደር አካባቢ አሁን ኮንፍሊክት ምን አለ የሰርቫይቫል ጥያቄ ነው። እነሱን ብሌም ማድረግ አንችልም። ሌላ ቦታ ያሉትን እህት ወንድሞቻችንን ግን በምንችለው ሁሉ እና በሚችሉት አጋጣሚ እንዲገቡ ኢንቫይት አድርጓቸው። እሺ እኔም እንድበረታ እናንተ መበረታት አለባችሁ። መታችሁ የማትሳተፉ ከሆነ መታችሁ የማትካፈሉ ከሆነ የማትመልሱ ከሆነ ምናምን እኔም ዲስከሬጅድ ሆናለሁ። you must be the reason for me to go on this track ማለት ነው። እና በቃ ለእናንተና ስል ብዬ የማደርገው ነገር መኖር አለበት። የሆነ ግሩፕ ሲኖር ምሳሳለት ግሩፕ ሲኖር እንዴት ነው በቃ I don't want to fail them። ቢደክመኝም ቢያመኝም ቢርበኝም ማረፍ ብፈልግም I have to do it ብዬ I need to have a reason to come ማለት ነው። እና ያንን እንድታደርጉ ለማለት ነው። ስለተሳተፋችሁ በጣም ደስ ብሎኛል። you guys are amazing, your knowledge is beautiful, I appreciate you። እና በደንብ በርቱ። ከዚህ ደግሞ እየተረዳዳን ደግሞ ከዚህ በላይም አቺቭ ታደርጋላችሁ። እና sky is the limit። thank you if you have any feedback ጥሩም መጥፎም ወይንም ደግሞ መሻሻል ያለበት መለመድ አለበት። ለኔም ፎርዋርድ መጣችሁ መናገር መቻል አለባችሁ። ፊድባካችሁን ደግሞ ባውቀው ደስ ይለኛል። መርካታችሁን ወይም አለመርካታችሁን ከዛ በጣም ደስ ብሏችሁ ከሆነ አውል ኪፕ አፕ ይሄንን የተሻለ ለማድረግ ሞክራል። ደግሞ አይ ምንም ሳቲስፋይድ ካልሆናችሁ ደግሞ ኖ ፈቃደ you have to do a better job ይሄንን አሻሽል ማለት አለባችሁ። እና አንድ ሁለት ሰው ኮሜንት ይስጥና እንዝጋ የዛሬውን ፕሮግራማችንን። whoever wants to say something.
Thank you so much, Doctor. It was a very interesting discussion. Now, can we get the slides?
Yes. ሼር ይደረጋል። ቪዲዮውም ሼር ይደረጋል። ከቪዲዮ ጎን ስላይዱም ሼር ይደረጋል። ይሄ የእናንተ ነው። እኔ እንደ ድሮ መምህር አይደለሁም። ያስተማረበትን ስላይድ እና መጽሐፍ ደብቆ ፈተና ላይ ማፋጠጥ አይደለም። ይሄ ፐርፐዙ የተሻለ ሐኪም ሆናችሁ ኢትዮጵያውያንንም ሆነ በዓለም ዙሪያ ያለ የሰው ልጅ መልካም ሕክምናን ፕሮቫይድ እንድታደርጉ ለማብቃት እስከሆነ ድረስ ይሄ የእናንተ ነው። ዩ ኦን ኢት። ሪከርዲንጉም የእናንተ ነው። ስላይዱም ልካለሁ። አሁኑኑ ዛሬውኑ ልካለሁ። ዜክስ ዩ አር ስሊፒንግ። አንተ ሰውዬ ሌላ ከነዚህ ጁኒየሮች ከሆኑ እዚህ ያሉት ዴሊጌት አድርጋቸው። አሁን የኮሪያ ልጆች ከጥቁር አንበሳም በቃ አክቲቭሊ ኢንጌጅ ማድረግ የሚፈልጉትን ልጆች አይደንቲፋይ አድርግና ከግሩፓችን ውጭ ቢሆኑ ሼር በማድረግ ቪዲዮ ኤዲት በማድረግ ይርዱ እና ያንን የቡክ ፕሮጀክቱንም እዚህ ላይ አናውንስ አድርግ ብላ የነበረ ውል አናውንስ ዛት ኢፍ ዩ ዋንት ሚ ቱ ዱ ዛት
yes definitely
ልናገር እሱንም
ዋው ጥሩ ይመስለኛል።
ምን መሰላችሁ ባጭሩ በአንድ ሴንቴንስ እኔ ሬዚደንት እያለሁ ፌሎ እያለሁኝ ሳጠናባቸው የነበሩ ደብተሮች አሉ። የእኔ አጠናን ስታይል እያነበበ ኖት የሚይዝ ሰው ነኝ። እኔ አንብቤ ዝም ብዬ አላልፍም። ኖት መያዝ አለብኝ። ሃይላይተር አላምንም። መጽሐፍ በማቅለምም የሚሆንልኝ ሰው አይደለሁም። የእኔ ታይፕ ያነበበውን ነገር አሳጥሮ በመጽሐፍ ነው ኪፕ ማድረግ። በዛ ምክንያት በጣም ቢዩቲፉል የተዘጋጁ ኖቶች አሉኝ። ኦቨር ዘ ይርስ ያነበብኩባቸው እንጠቀምባቸው ከተለያዩ ሪፈረንስ ትልልቅ መጽሐፍት የተጻፉ እነሱ ደብተሮች ብዙ ሰዎች ተጠቅመውባቸዋል። ለእኔ የቀረቡ ሰዎች ብቻ ማለት ነው። ማቃቸው የሚግባቡኝ ልጆች እባክህ ይላሉ፣ እሰጣቸዋለሁ፣ ወስደው ይጠቀማሉ። ሲጨርሱ ያመጣሉ፣ ሌላ ሰው ይወስደዋል። እንዲህ ያለ ሲንከባለል ብዙ ሰው ተጠቅመውበታል። እና ምን አይነት ሀሳብ መጣልኝ? እኔም ማውቃቸውና ለእኔ ቅርብ የሆኑ ሰዎች ወይም እኔን ማግኘት አክሰስ ያገኙ ሰዎች ብቻ ከሚጠቀሙበት ይሄንን ኖት እኮ ታይፕ ብናደርገው፣ ታይፕ ማድረግን ብቻ ሳይሆን በመጽሐፍ መልክ ፒክቸሮች ምኖች ሞር ኦርጋናይዝ አድርገን ብናዘጋጀው እንደ ስታንዳርድ ቴክስት ቡክ ባይሆንም እንደ ኩዊክ ሪፈረንስ ግን ሊያገለግል ይችላል። ወይም ደግሞ እንደ ሪቪዥን ማቴሪያል ሊያገለግል ይችላል። ለእኔም ሪቪዥን ስለነበረ እና በዚህ ኢኒሽቲቭ ብዙ ገንዘብ ከፍዬ ታይፕ እያስደረግኳቸው ነው። እነዚህን ኖቶች ማለት ኖትቡኮች ሰጥቼዋለሁ ለሰው የምትጽፍልኝ ልጅ አለች። የተጻፈውን ግን ኤዲት ማድረግ የሚቀለኝ መስሎ የነበረ ሞከርኩት፣ አልቻልኩም። ጊዜም የለኝም እንደምታዩት ነው ብዙ ነገር ላይ አክቲቭሊ ኢንጌጅ ስለማድረግ። ስለዚህ ኦፖርቹኒቲውን ወስዳችሁ በተለይ ገና ሲዋን ያላችሁ ልጆች ደብተሩን በዛውም እያነበባችሁበት እግረ መንገዳችሁንም ደግሞ ታይፕ የተደረገውን እግረ መንገድ ኤዲት እያደረጋችሁ ክፍት ሰዓት ሲኖራችሁ ጎን ለጎን ፕሮዳክቲቭ ስራ ብንሰራ ለዚህ ፈቃደኛ የሚሆኑ ልጆች ብናፈላልግ ብዬው ዜክስ ኃላፊነቱን ወስዷል። ሁኤቨር ኢዝ ኢንተረስትድ ግቡበት፣ ለዜክስ ንገሩት። ግን አንድ ነገር የማሳስባችሁ ምንድን ነው፣ ያው አዳልት ስለሆንን በሪስፖንሲቢሊቲም ስለምንንቀሳቀስ የማሳስባችሁ ነገር ምንድን ነው፣ ሰልፊሽ ሳንሆን በቃ ስተዲ ማቴሪያል አግኝቻለሁ ኤዲት ተደረገ አልተደረገ ምን አገባኝ በሚል ሴንስ ሳይሆን አይ ፈቃደ ስላሴ ያሰበው ነገር ጥሩ ነው፣ እኔም እጠቀማለሁ፣ በዛውም ኤዲት አድርጌ ደግሞ አክኖሌጅመንት ውስጥ ገብቼ እኔም ተሳትፌበታለሁ የምለው ነገር ይኖራል የምትሉ ልጆች ካላችሁ ካም ፎርዋርድ እና ሌትስ ዱ ዛት። እሺ
ዶክ after this do you have like 5 minutes? ትንሽ ማዋራ ነገር አለ።
እሺ ለእኔ እናንተማ እናወራለን። ስጨርስ ደውልልኝ በዋትሳፕ። ሌላ ኮሜንት መስጠት ከሴቶቹ ከእህቶቻችን እስቲ አንዳችሁ ተናገሩ። አሁን ደግሞ እኮ ሴቶች እኮ you are coming forward to leadership ከኛ እንደኛ ጊዜም ቁጥራችሁ ትንሽ አይደለም ብዙ ናችሁ እና መናገርም አትፍሩ፣ አይዟችሁ። እኔ ደግሞ አላስፈራም። ላጥፋው ቪዲዮውን አላያችሁም እኮ ዞሮ ዞሮ እናንተ ቪዲዮ ጠፍቷል። እናንተ የምታዩኝ እኔም አላያችሁ። አንዳችሁ ተናገሩ፣ ቮለንቲር አድርጉ። ቤዛ፣ ሊያ፣ ጆቤድ፣ ጆኬቤት ዋን ኦፍ ዩ።
አይ ቆንጆ ሌክቸር ነበረ። in a very short time ስትሮክን ሪቫይዝ እንድናደርግ ጠቅሞናል።
በጣም አሪፍ። ኤልሳቤት do you want to say something? ካሜራ እንትንሽ አንሚት ስታደርጊ ስላየሁሽ።
እኔም ዛሬ የመጀመሪያ ነበር ስገባ and it was very interesting. ስትሮክን አንድ ሳምንት በፊት አንብቤው ነበር እና አሪፍ ሪቫይዝ ማድረግ ሆኖልኛል በጣም and the basics ላይ ፎከስ ማድረጋችን especially the history and the physical examination እሱን በጣም ወድጀዋለሁ። thank you።
በጣም በጣም ጥሩ በቃ እሺ፣ በጣም አመሰግናለሁኝ። ይሄ ፕሮግራም ይቀጥላል። እግዚአብሔር ከረዳኝ በሰላም ካቆየን በሰላም ካገናኘን ኔክስት መንዴይ ሌላ ለማድረግ እንሞክራለን። ያው እቅዳችንም እንደዛ ነው። በየሳምንቱ አንድ ቀን ለማድረግ ነው። ወርክ ዊኬ ከመጀመሩ በፊት ባለኝ እረፍት ነው የማደርገው። ስለዚህ ሰኞ ማክሰኞ ስለሆነ ስራ የምጀምረው ሰኞ ሌላ ሴሽን ለማድረግ እሞክራለሁ። አስቀድመን አድቨርታይዝ እናደርጋለን። ቶፒኮች ፕራዮሪቲ እንዲሰጣቸው የምትፈልጓቸው ቶፒኮች ካሉ ለዜክስ ላኩለት። ዜክስ ይልክልኛል። እኔ የእናንተን ምርጫ አይቼ እርጀንሲውንም ደግሞ እኔም አስቤበት እየመረጥኩ በእነዛ ኬዞች ላይ ዲስከሽኖች ይኖሩናል። ሌሎች አቴንዲንጎች ስፔሻሊስቶች በየሰብ ስፔሻሊቲያቸው እየገቡ እንዲያስተምሯችሁ ልክ እንደኔ እየሞከርኩ ነው። ግን ፒፕል የምትጠብቁትን ያህል ፎርዋርድ አይመጡላችሁም። አልችልም፣ አይመቸኝም እንደዚህ ብዙ ጨርቄን ማቄን አለው እና በሰው ላይ ደግሞ ዲፔንድ አድርጌ ይህን ፕሮጀክት መግደል አልፈልግም። ስራችን ይጠራቸዋል ብዬ ተስፋ አደርጋለሁ። ግን በደንብ መስራት አለብን፣ ማሳየት አለብን የምንሰራው ስራ ፕሮዳክቲቭ መሆኑን። ስለዚህ እንዳትቀሩ። ዛሬ ያላችሁ ልጆች እንግዲህ ጥቅሙ ጠቅሞናል ካላችሁ ኔክስት መንዴይም እንደምንም ማመቻቹና ማታ ስለሆነ ለመገኘት ሞክሩ። ጓደኞቻችሁንም ጋብዙ። ጥሩ ነው፣ በጣም ወደነዋል፣ ተምረናል። ዩ ሚስድ ኢት በሉና አውሩ። አጋናችሁ አምባሳደሩኑ ማለት ነው። አጋኑ። በስማም እንደዚህ አይነት ስትሮክ አይተን ሰምተን አናውቅም በሉ። አጋኑና ብዙ ሰው ጠርታችሁ ለሰኞኑ ለማለት ነው። በተረፈ እግዚአብሔር ይባርካችሁ ሁላችሁንም በያላችሁበት። ጉድላክ በጣም አመሰግናለሁ። በቃ ይበቃናል እዚህ ላይ ዜክስ ቡራኪዮት ይስጡንና እንዝጋ። ብሩክ ያለ
አለው በጣም እናመሰግናለን። ቴንክ ፎር ዮር ታይም በጣም እና ሆፕፉሊ ያው ፕሊዝ ሌት ሚ ኖ እንዴት ጆይን ማድረግ ነው የምትፈልጉ። ኦልሬዲ ቲም አለን እየሰራ ያለ፣ ግን ኤኒ ካይንድ ኦፍ ኢንፑት በጣም ይጠቅመናል እና ፕሊዝ ሌት ሚ ኖ።
አዎ ይሳተፉ። ገባ አሁን ሳየው ቲሙ ውስጥ ያለው ሰው በተለያየ ምክንያት ሳይችል ቢቀር እንኳን እንደ ከቲሙ ውጭ ያሉ ልጆችም ገፍተው እንዲመጡ ፈልጋል። አሁን እንደውም ኔክስት ዊክ ያው ዛሬ እኮ ሆስት ያደረኩት የእናንተን ልጅ ነው። እንትናን ማን ሊሮይን ነበር ያደረኩት የሾላካ መሀል ላይ ወጥቶ ሄደ እንጂ እና ኔክስት ዊክም ደግሞ ከእናንተ መካከል ኢንተረስትድ የሆነ ቀድሞ ከኔ ጋር ተገናኝቶ ኬዙን እነግራችኋለሁ ሚንስ ፕሬዘንቲንግ ኮምፕሌንቱን ብቻ ከዛ ሞዴሬት በማድረግ ምናምን ትረዱኛላችሁ። እንደገመቹና እንደንትና ገመቹም ለምን እንደወጣኝ ታይም ኪፐር የነበረ። ስለዚህ ሞር ኢንፎርስ እያደረግን እንመጣለን። ታይምም እንዳያሳስባችሁ ኦልሬዲ ያለን we are working on it። ለእያንዳንዱ ሴግመንት ታይም ዴዲኬት እያደረግን ነው። ዴይ ዋን ስለሆነ ሪስፔክት አላደረግነውም። ወደፊት ግን as we go along we will be better እና እሱን አስቡ። በቃ በሰላም ያገናኘን። መልካም አዳር ይሁንላችሁ። በርቱና አጥኑ። ጎበዝ ሐኪሞች ሁኑ። ለሀገራችሁም ለዓለምም ሰላም ሁኑ። ባይ ባይ።